And the heterogeneity of a biological. That's very important. And of course, a biological can be immunogenic. And the generic drugs, they're chemicals and they're non-immunogenic.
So we understand that the biosimilars can be actually immunogenic. That's very important property of a biosimilar, which has to be similars. So it is a European Union decision to call them biosimilars. And US FDA calls them follow-on biologics. So follow-on biologics can be biosimilars, bioequivalents, they can be bio-betters. That's why US has chosen the terms follow-on biologics. And then what does India call them as? They call as similar biologics. So WHO calls them similar biological products. So these are all same definitions, follow-on biologics in US and biosimilars in Europe. So, Dr. Prahlad, once we are convinced that they are so good molecules, what are our real concerns with them?
The main concern is of safety. Although by taking approvals, we can be assured there is equal safety, equal potency and efficacy. Otherwise, even despite of approval, there may be a little bit of variations may be there because it has been seen even with the biologicals, there may be different, slightly different response maybe with the, because of the complex process of manufacturing, there may be a slight variation in batch to batch. So although by approvals we can assure the quality, safety and potency, but still we have to be taken care by replacing them with any of the biologics in place of biosimilars or similar biologics.
So what are the regulatory requirements for biosimilars and how does it differ from the innovator brand?
When we talk about the regulatory requirements, whenever any biologicals is developed, there is initial process of analytics, and then there is a process of preclinical study, clinical phase 1 study, clinical phase 2 study. But when we go for the biosimilars, there are major contribution is analyticals, because everything has been done. Effectiveness of the biologicals have been proved. So the important, they have to look for they go with all the data which is available in the process of this. Although it is secret, one cannot utilize because of the patent, these things cannot be utilized in producing these drugs. Once the patent expires, you can have a different kinds of mechanisms by which you can analyze and then do preclinical study and the clinical kind of approval like phase 1, phase 2 studies and phase 3 studies.
So the whole pathway of innovator drug is very lengthy with respect to a lot of preclinical, clinical pharmacological studies and the phase 1, phase 2, phase 3. So developing a innovator brand takes around 10 to 12 years, while this pathway can be shortened for the biosimilar products because they go on lines of, though it is innovator molecule is a propriety of the innovator, the reference molecule which they call as. They do not provide anything else apart from the exact molecules. So once somebody is developing biosimilar, they go into a lot of its analytics matching the molecule. So it is kind of a reverse engineering that they do, and they go with a lot of analytical proof for that. The number of preclinical study, clinical pharmacological studies and clinical case study pathway is shorter for them. So developing a biosimilar would take 5 to 6 years, and the costing of developing a biosimilar is actually 1/10 of the costing of the innovator brand. So what is the end result, Dr. Prahlad? Once we approve them, how does it compare to the reference product?
Whenever approval, we got the approval, it means whether the approval is from the FDA or the European Medical Agency or Indian, as per Indian law, it is equally safe, it is potent and effective. But certain issues are there which has to be taken care, like interchangeability has to be taken care, which is not being addressed in Indian law.
So finally, end result is that in all the countries, the law is so stringent for biosimilars that finally it is going to be the same protein, it is going to work the same way, it is going to have the same safety data, it is going to have same efficacy data, and both would undergo post-marketing surveillance also. But biosimilar would have initially fewer clinical studies.
That the patient ends up taking either open glimepiride or some other company glimepiride. So usually that kind of changeability, interchangeability happens at the chemist level or even at the patient level when it's to the cost of the drug. Usually most of them would be almost similar. Now when it comes to biological product, it's very important whether the patient or the pharmacist can himself change that without the doctor's prescription. Now that approval comes only when early there is demonstration of not only the similarity in terms of efficacy, durability, all the safety issues, less immunogenicity, but also the fact that the clinical effects of the molecule will be exactly similar to the innovator product. And those kind of studies are done. The US FDA gives an approval for changeability, which means without even the doctor's prescription, the patient can freely go from the innovator to the biosimilar product because maybe a lower cost, better affordability, better access. So that is why the interchangeability label has been given only to very few molecules, very few biosimilars, and in India we have the EDPACON2022 which is globally US FDA approved in terms of interchangeability. So even without the doctor actually telling you change from the innovator glargine, the pharmacist, the patient, for whatever reasons, including the cost, can easily switch to the biosimilar as good as the innovator with similar clinical as well as all the safety data.
So the biosimilar company has to demonstrate interchangeability by doing a switching study. That you have different kind of studies that in which you use a reference molecule, then you use a biosimilar, then you again use a reference tool. On the other side of the arm, you use a biosimilar followed by reference, then biosimilar. So these two parallel switch alternating arms, and you find the same effect and efficacy. Then you call that it can be interchangeable. Now it's used to the pharmacist. Now doctor's description is gone. Say it is interchangeable. Even the pharmacist can interchange it. So biosimilarity, interchangeability, that gives rise to interchangeable biosimilar definition, which we call as bioequivalent. So, Dr. Prahlad, do we have these stringent laws in India also?
Yes, although first biosimilar hepatitis B vaccine was launched in India in 2000, but regulatory was formed by central drug organizations in 2000 along with the and that time the law was not that stringent, and it was just on the case-to-case basis. But finally in 2016, with the central drug agency as well as Department of together make stringent laws in which they have strictly taken care of all the aspects of manufacturing's variability and any aspects of this. Any aspects they have not dealt with interchangeability. Things have been included in this. So our laws are at par with the European Union as well as European Union.
So thank you very much. With those laws comes what we regularly listen in our clinics. Doctor, वो प्रधानमंत्री वाली दवाई ले लूँ? Dr. Meena, how do you tackle these queries in your clinic? And how good are they? What is the backing on the Pradhan Mantri Janaushadhi medicines which are available?
Since Pradhan Mantri's name is there, all of us should refrain from saying that they are not good. It's not because I mean,
So make in India. That is make in India.
But one thing is important that I have a Pradhan Mantri Yojana Janaushadhi store and I periodically go and check whether he's keeping the insulin in the fridge. So let's be honest, it's just not about biosimilarity, but how insulin is stored. That is more important. So drugs, outside most of the drugs, there are some which have to be stored in cool temperature. I'm facing is only glargine is available. Now, is it biosimilar, or so several other companies which don't have approval as interchangeability are also available. So now that glargine, if you check, has no trade name, it's glargine. And the pen that is available, it's a similar pen they get for glargine and for regular. So there is some free pen to them. The cartridge can crack because pens are different for different insulins. So I am actually not very confident about cold chain. So do say you or say a dapagliflozin from there, but I think unless my patient is really poor, and even poor patients who have type 1, I prefer giving them, I don't send them to this place, but yeah, cold chain is an issue there because they might soft their...
so we have to just quickly do few of the courses which are left. So what is the reality in our clinical practice, Dr. Shalini? How are we taking this further, convincing our patients about biosimilars or these generics? Do we go ahead with this idea,
Yes,
or do we discourage them?
Yes, with all the proof coming in, and if they are able to prove that they are actually biosimilar to the innovator product, it's a huge market that's growing. We already have more than 20 approved biosimilars, 70 are in the pipeline. A lot of them are being used globally as well as in India, and India has a lot of companies that are manufacturing biosimilars, with Biocon probably being one of the leaders when it comes to biosimilars. So the benefits are great, the cost benefits are good. So yes, they can definitely be used if they prove all the standards, they prove everything and get their licensing, why
so
not?
we go ahead with the idea of biosimilars, and we have to make our laws stringent, and we'll go with Make in India initiative, and Pradhan Mantri is to be encouraged. With greater affordability, improved drug access, and the price war, it becomes cheaper for the public. And these reference products, biosimilar products and interchangeable products are now going to be in thing. So what is the current state of biosimilar adoption in diabetes care, and what factors are driving or hindering it? Very brief, quick.
Very
30
briefly,
seconds.
I think it's the price.
Yeah.
The product has a quality product, of course. The science behind
What
it
is
has
this
to be good,
success
and
story
then
of
the pricing.
Success story of Biocon in US? Just very briefly.
Obviously, after the interchangeability approval, I think the US market has actually impacted the global market when it comes to biosimilar insulins, first of all. So the affordability has come in, and they've saved like millions and billions of dollars. Even in India, I think.
So it's not only Make in India, it's Make for the world.
Yes.
So
So
that
I think,
all should be proud of.
yes, we should be proud. Our Indian companies' biosimilars are globally approved, being used all across US as well as Europe. So the access, the affordability, and the quality of the product is what is most important.
So that is the target of Indian
Yes.
pharma industry, that 2/3 of the biological use across the globe would be an Indian story
Absolutely.
by 2030. Malab, that is what is by 2030 will give you the data that how we are rapidly growing. India was the first country in 2000 to approve Hep B vaccine as a biosimilar, and it is one of the leading contributors for more than 100 biopharmaceutical products, biological products. So Dr. Prahlad, what in terms of dollars? Very quickly, please.
Definitely, if you see global market, by 2030, we project around 240 billions market will be there. But as far as India, it will be around 35-40 billions dollar. So it's a market is big, and every year it is growing from 14% average. And there are, so definitely it's time is going to come where the biologicals with the biosimilars are.
Dr. Lalit, please come to the dais. So, Dr. Ina, are there few biosimilar products for diabetics?
We want particularly liraglutide, because you need biosimilar, because again, that's a drug which is very good, a GLP-1 receptor agonist, and it is in the pipeline. But again, here I repeat that biosimilars, if a particular company is making a particular insulin and marketing it at two different prices, that's not biosimilar. That is also happening. Then that,
Alright. So we have
yeah.
a lot of biosimilars in pipeline with GLP-1 receptor analogs also. Now I'll go to my chairperson's. DM occurred. How about switching decision? It should be by physician or it should be?
So for India, I believe we have to be very careful. We know the level of the pharmacists that we have here in India. So I think in our country, it's especially very important that the doctor fully takes charge of whether a person needs to switch or interchange. But in the Western countries, of course, the situation is a little different.
So are you convinced that biological reference products and biosimilars would go hand in hand with dosage form, safety, and route of administration, purity, potency? So that's the beauty of biosimilar, that at a lower price, you would have all the qualities of the reference. So biosimilars are going to provide more treatment options, more competition in the market, and lower cost. So what is beyond biosimilars? Last 1 minute. Dr. Rajesh.
So beyond biosimilars, biobetter. Actually, they are targeting the same protein, but with some minor changes in the structure as you started, maybe the change in some folding pattern of the molecule. The effectiveness is better, the side effect profile is better, the safety
Very
profile
rightly
is better.
said. So biosimilars can be tweaked to evolve into biobetters with respect to their route of administration, and storage criteria also. But can what is the best biobetter going to be? What threat we as a human have as biobetter? So AI is the biobetter of humans, which we need to vary of. With that, we conclude this talk. Thank you very much for your patient listening. If there are any queries, please.
If there are questions by the audience, they are free to ask the panelists and the speakers.
But very quickly, we'll just take two questions because we have done over.
Meena, I think of late the patent of this comparator has gone, right? And they are coming at a lower cost. The reference product for glargine has gone. The patent is off now. Thanks. So they have reduced the price. So is there any difference between now the costing, as we are just talking about, between biosimilars and...
I say it's not the cost of insulin alone which matters. The cold chain is very important. How it is stored is very important. So when we talk, it's not about the cost per unit. Now it's not much different. But here in US it is. Can anybody guess the price of an insulin vial in US or a cartridge? It's almost $450, which makes it about 40,000 rupees. So we are very lucky to be in a country like India where a regular insulin can cost 150 rupees.
So I'll request my chairperson and faculty to come for the celebrity pick, and I hand over the mic to the. Thank you.
Thank you so much, sir. Now I will request the speakers and chairpersons to kindly proceed to the felicitation area. Dr. Lakshmana Sani and Dr. Nishesh, sir, kindly felicitate the speakers. Now proceeding to our next session, a novel approach addressing the syndemic diabetes and weight, I would like to invite the chairpersons, Dr. Anshuman Srivastava, Dr. D. Dubey, Dr. Rajiv Bansal, and Dr. Vivek Bindal. Kindly proceed to the desk, sir. Dr. Anshuman Srivastava is assistant sir at the GTP hospital. Dr. D. Dubey, consultant at Max Vaishali. Dr. Rajiv Bansal is consultant and director at East Delhi Cardiac and Diabetes, Krishnanagar. And Dr. Vivek Binder, Head of Department, Institute of Minimal Access and Pediatric and Robotic Surgery at Max Super Speciality Hospital, Vaishali. For this session, I would like to invite a speaker, Dr. Rishi Shukla, on the stage.
Hello, everybody. I'd like to introduce the speaker, Dr. Rishi Shukla. We have one more Rishi here, not Rishi Shukla, Dr. Rishi Shukla. And he has held several positions. At present, he is HOD of Endocrinology and at Regency Hospital, Kanpur, Chief Consultant, Center for Diabetes and Endocrine Diseases, Kanpur, India. His publications, national and international, all more than 50. Awards and certification, recipient recognition award, Economic Times 2018, and IMA Kanpur Ratna Award 2022. I'd like to invite Dr. Rishi Shukla to give his talk.
Good morning, friends, and thank you, sir, for kind words. And before I start, a big thanks to Dr. Ajay Gupta, Dr. Vishesh Jain, and a special thanks to Novo people, Jagjit, Parul, our local Gaurav, and Ankit. I think just sit down and relax for 10-15 minutes. I'll be talking a bit of science and a bit of life too. So let us enjoy 20 minutes. I have 20 minutes. 20 minutes? All right. So this is life. And just 10 days back when weather was a little cloudy and I took a picture. So life is beautiful and so is the science. And what am I going to discuss is the unmet needs, a bit about semaglutide, weight loss by GLP, and benefits early in therapy. Three terms we very commonly use: glucose-centric approach, weight-centric, and patient-centric. What all are they and how should we proceed? I think the key lies with you. Not it is with you. The type of approach you decide. Introduction, you sir, little inadequate. I always use a word for myself. I am a storyteller. So I'll take a minute. Long back, 1500, 2500 years back, there was a man known as Buddha who enlightened the world. And what he did a wonderful thing, and it is to control mind. If you control your mind, I think you can do many things. And he controlled to the tune all big people, all kings, their ministers and everybody. And finally it reached to the people. Everybody rushed towards him. And they took out their clothes, they took out their ornaments, and finally they gave it to their servants. And what happened? Servants said, ki, hum hi akele bewafoof thodi hai. I also want to proceed on the path of man. So they hanged their clothes and jewelries into the trees. So this is what the story, and why am I telling you is the reason. Because the approach you take to manage diabetes is what way you want to go. You want to go for a basic approach, that is man approach, or to control the glycemia. So one is the weight-centric approach, the harvesting approach. Another is the glucose-centric approach. And what is weight-centric approach? If you manage the glucose-centric approach, see from where these problems are coming. The diabetes, hypertension, obesity, dyslipidemia, osteoarthritis, polycystic ovarian disease, all of they come from one source, and that is insulin resistance, and from where insulin resistance is coming, and that is weight gain. So it is up to us whether we want to have attack at the basic, because if you attack here, then probably you can avoid all these things, dyslipidemia, osteoarthritis, or you can avoid hypertension and then further dive. So approach is up to us, and opportunity lies in intervening upstream to address the key. If you go for the weight loss, the very basic thing that occurs is disrupting underlying pathophysiology and reverse or slow down disease, and which in turn promotes blood sugar control, and it controls not only blood sugar but I think many more things. The GLP-1 receptor analog is known for weight-centric approach and it has directly 3 benefits. They are very efficacious, hypoglycemia risk is negligible, weight loss. Weight is, I think, over 60-70% patients are overweight. The CV benefits are definitely there to many GLP-1 receptors. When I started endocrinology, if you recall diabetes prevention trial, they said 5% weight loss is sufficient. Now we have increased to 10%. Now we talk about 10, 20, 15%, and now say you can lose as much as possible and you'll reap more and more benefits. But weight loss has benefits in terms of improved quality of life. It has a disease-modifying effect, metabolic improvement, cardiovascular. So all these things are happening. And how does it act? I'll tell you the basic thing that the hypothalamus has GLP-1 receptors and they act by 2 modes. They reduce hunger, energy and food cravings, and at the other end they take care of satiety. So they make you eat less and satisfied more. So prevents overeating and then altered food preferences. What are unmet needs in weight loss? Sustainability, because once you lose, all of us, if I look at myself, I lose 5 kg in 2 years, again regain 2-3 kg, then 2-3 years, and this must be happening to many of us. So sustainability of weight loss is a very challenging issue. Long-term glycemic control, because if weight is not consistent, then the CV factors and the glycemia. To address this, we have a molecule, GLP-1 receptor agonist, and the thing is, they are highly effective, excellent body weight reduction, low hypoglycemic risk. Mind you, low glycemic risk is only when you are not using any secretagogue or insulin. And there are benefits. Easier to titrate, not much, 1 or 2 or 3 dose titration, and side effects again are less, but many of the patients are able to tolerate. A small proportion of patients receive medication with proven weight benefit. That is the fact. If you look at GLP-1, this data is coming, 60-70% population should use, but only 9% are using. But I beg to differ with the data. Now with availability of dapagliflozin at a cheaper rate, SGLT2 inhibitors at a cheaper rate, many of our patients are using. So at least we are using one weight reducing and disease modifying agent. This is a busy slide, but I will be briefing. This is oral semaglutide, must have seen couple of times in different states like exercise as an add-on to OAD with insulin, special populations. And what it does, the maximum weight, maximum agency, 13 milligrams semaglutide was 1.5. So which is quite good. Look at all other oral hypoglycemic agents, 0.5, 0.6, 0.7, not more than that, up to 0.4. If even then what was this setting? Up to 2.6 HB. Weight reduction again is a, but if you use semaglutide with comparison to different molecules, empagliflozin, seta, even with liraglutide, the semaglutide proved little superior. So up to 5 kg, again I am telling you with maximum doses of 14 milligram. So this molecule gives 1.5 gram percent of A1C reduction. A1C is more than up to 2.6 and up to 5 kg. But weight loss, one thing I would like to say that weight loss at times is much more. People lose 7 kg, 8 kg, 8 kg. I remember with GLP-1 I've been using long back and people lost up to 25, 30 kg. So again the individual experiences are very variable. The weight loss, weight targets with oral semaglutide, 5 to 15. patients lose more than 5%. And 10%, 1 in 5, that is 20% patients lose. So this is the most advantageous thing. And what is important is people by and large lose fat part, not the lean body mass. If you look at this, compared to placebo, 2.6 versus 0.6 fat, and 0.1 and 0.5 the lean body mass. So lean body part or the protein part or the muscle part as such does not go down. So when you lose more, the benefits are more. And this is the 1-year data of look-ahead trial. And as the weight loss is more is the blood pressure loss. As the weight loss is more is the triglyceride loss. As the weight loss is more, decrement of LDL. So probably these are the things that lead to cardiovascular benefits. A loss of 5% body weight in the year following diabetes diagnosis was associated with improvement in factor and a 48% lower hazard for cardiovascular risk for 10 years. So this is a huge advantage. It also takes care of reduction of HSCRP, systolic, diastolic blood pressure. I have already told. If everything will happen, the waist-hip ratio will also go down. So reduce your weight and increase quality of life. What is most important is early initiation of oral semaglutide. This is the data with early initiation and 3, 7, 14, 3, 7, 14. So this is 1 year, this is more than 1 year. So even after 1 year, the proportion of patients achieved A1C 6.5 was quite a lot. And 8 out of 10. If you look at the data that I have shown, only 50% patient are. So the target's achievement is easier if we use early. Early treatment initiation can lead to prevention of complications. Very true. And major benefits are in terms of glycemic control, diabetic complication, healthcare cost. This molecule has a proven efficacy in terms of large experience. I think now most of us have experienced widely, so we know good and bad of this molecule. Adverse effects, we all know. Hypoglycemia, we all know. No new unexpected safety findings on oral semaglutide. So we all know what is good or what is bad. Hepatic and renal impairment, even GI tract disease, we can use it. So no dose adjustment is required for elderly patients, upper GI disease, hepatic impairment, or renal impairment. Life is beautiful, but not everything is. I'm asking you a question. Do every patient needs a body-centric approach? सबका weight आप कम कर देंगे तो काम हो जाएगा. Because again, the key persons are you, not me who is telling you all those things. And look carefully this. You have to differentiate your patients, whether patient is having adipose-related diabetes, whether patient is having cardiovascular-related diabetes, or it is isolated hypoglycemia or lean type 2 diabetes. So depending upon that, your approach should be there. If it is adipose-related, the key factor is weight. And if you lose, and here a very intelligent approach would be, because cardiovascular risk immediately is not there. You can protection. As against if there is an existing cardiovascular disease, which is again 30 to 40%, even up to 50% of the population, to give SGLT inhibitor and receptor agonist with proven benefits. As against the isolated hypoglycemia, more focused on controlling blood sugar, because you have to protect. So you have to individualize the approach, and that is very important. So this molecule reduces HbA1c up to 1.56, weight loss more than 5 kg, systolic blood pressure 5 or more than 5, takes care of lipids, waist circumference. And don't look at. So I'll go. And we mind. AI people were already talking. Look, last week I was at Suraj Kund Taj and my host asked me to taste these. They said this was food testing, and looking at it, is it easy to avoid temptation? No, sir. It is difficult. But we have some control our mind. If we are taking GLP-1, no, I can't have that much. It is all right. I had a word with chef also. हमने कहा यार तुम इतना खाते हो तुम अपना कहा नहीं. Then I said Sanjeev Kapoor और बाकी वाले को तो सब पतले पतले हैं, because he was the person who was in charge. 4 chefs were working before him for that party. I just understood the story on that day. कि सर वो सब हमारे ऊपर ठेल लेते हैं, वो तो पतले बने रहते हैं, टेस्टिंग का काम सारा हम ही करते हैं. So a salt who can take care of. We have gone beyond brain. We have gone at, if you are not able to control your man, use salt, because the GLP-1 analog, the appetite, the fullness, the will to eat tremendously. They have reduced tremendously. And finally, the easiest explanation to take care of, get a photograph with your friend who is fatter than you. You'll because the last, I think, Diabetes India also. If you lose interest in food, then what is left? But again, a balance is involved. Buddha again said a final thing, understand. जो सुख दे ऊर्जा दे दुख ना दे. I think still I have 4 minutes, we can have a discussion. Summary. Oral semaglutide is world's first peptide pill and has efficacy significantly better than active comparators, better than even liraglutide. Oral semaglutide is an effective option for type 2 diabetes management along with its effect on weight loss. Everything fine? So it is very effective, and oral semaglutide acts through central nervous system pathways. I showed you hypothalamus has the GLP-1 receptors, so it works through that. It has shown to reduce weight up to 5 kg. I shared with you many of my patients GLP-1 on various GLP-1 reduce up to 20, 25, 30 kg, and the similar experience must have been with you people also. And it is easy to titrate and can be used in all stages of CKD, hepatic failure. So with this, thank you so much for your kind attention. Thank you so much.
Thank you, sir. Thank you for an excellent presentation.
Thank you, sir.
And I think we all know that obesity is the common soil cause of so many diseases. So we have to address obesity by somehow. And even as you said, 5 cardiovascular risk goes down by 50%. Must, and WHO has already mentioned obesity. We should not take it lightly. In every prescription we should have, and then the drugs. So thank you, sir. Thank you for enlightening us. And
any questions, comments? Yes, brother.
All efforts and with semaglutides. All lifestyle modification, semaglutide is also there.
to tell you my status, I think I am one of the largest user of semaglutide, one of the largest. It works well because I remember again बिल्कुल देसी भाषा में जवाब देते हैं. बहुत से लोग अंग्रेजी बोलने वाले होते हैं मेरे पास कि वो फलानी डाइटिशियन से ले लिया, मुंबई की वो अंबानी वाली डाइटिशियन से ले लिया, फलां से ले लिया, मैं ये कर. And you ask a question, what you will that नाइट मील स्कीम सर रात को तो खाते ही नहीं है. At least I have and semaglutide, and but they were motivated to take it, and they reduced weight. The magnitude might be less or more. If patient has tolerated, so I mean, that is my experience.
Sir, I think we are entered into the era of diversity, and Dr. Rajbans has rightly said that reducing weight just by 5 to 10% have a lot many advantages. Dr. Vivek is there. Dr. Vivek, we are talking about not diabetes patient with bariatric surgery. So you have been. What is your experience with patient who are obese, and what are the status of diabetes? Because sometimes say that 30% comes back after the bariatric surgery. So what is your opinion?
Thanks, Dr. Chaudhary, and wonderful talk, Dr. Shukla.
Thank
I
you.
think semaglutide we have been using for, and now it is oral, but we have been using Victoza and Trulicity for 7-8 years in our practice.
True.
In weight loss. I think it's a multitude of treatment modalities which we need to use, starting from diet, exercise, drugs like GLP-1s plus endoscopic therapies now, endoscopic sleeves, balloons, and then bariatric. With bariatric, we see the most sustained kind of remission of diabetes that Dr. Chaudhary is asking, and I think we did our own study. We looked at the levels of GLP-1 peptide YY as well as C-peptide levels and insulin levels after bariatric surgery, 6 months, 1 year, 3 years, as well as the changes.
I think key is to intervene as early as possible for any disease, for anything.
Can I ask a question? So thank you for the excellent talk. So what is your take on the millets currently promoted by Indian?
I think undisputed answer. They have a low glycemic and most of them are gluten free. We have started talking in terms of gluten intolerance. Gastroenterology, गेहूं और दूध सबको ही बंद कर उसने यार होती उसको करें. So millets are good. I was having breakfast in this hotel Le Marina. I stayed.
Diabetic dyslipidemia. I would like to invite our chairpersons, Dr. S.K. Palaha, Dr. Ghanshyam Pagde, Dr. Kunal Gupta, Dr. Sharad Joshi. Patpatganj and Cosmos Hospital. Day is a professor at for I would like to invite Dr. Saket Khan, Dr. Sanjay Tyagi, Dr. Shri, Dr. Saurabh Shishir Agarwal.
But the problem with is antibody, monoclonal antibodies, they are costly, require of course there are also antibodies are also available, which are I think they are not available here but available in the States. So these are the things which are available to us.
Thank you, sir.
Yeah.
Dr. Saket Khan, sir, so even after LDL cholesterol, that reduction that area is reduced much, not used much, even percent is persistent because eminent. So what is your approach in hypertriglyceridemia, which is persistent, which is per use of statin?
If you talk about cardiologists, they would not ignore that triglyceride risk factor of cardiovascular disease. They do not like to lower triglycerides. Only lower triglycerides if they are more than 500, and the risk of pancreatitis is very high. But if you look at recent data, yes, I would risk even after LDL less than 55, you got residual risk. 55, you maybe because of triglycerides. And if you look at recent data, they have to calculate the triglyceride to glucose ratio also as a risk factor for cardiovascular disease. And there is a good amount of publications, good amount of data on that also. My approach is also as per the ADA guidelines. I would like my LDL triglycerides to be less than LDL less than 150. Drugs for so first is for nutrition. Triglyceride 20% right, but now we got PPR alpha gamma full drug and triglycerides from around 2000 to even just about 300. But with alpha gamma ecoagonist, there is a problem that you can have responders. You can have very good responders. You can have very poor responders. The second drug that is phenofibrate, that has been there for a very long time. But the problem with phenofibrate is you're going to use it with a statin. The risk of having myopathy and rhabdomyolysis is very high. I had 2 or 3 patients admitted with rhabdomyolysis on atorvastatin. That is the preference by cardiologists with a phenofibrate. So you have to be careful with phenofibrate with high-intensity statins, atorvastatin. But I guess alpha gamma coagonist are a wonderful drug. You can achieve your very quickly with PPR alpha gamma coagonist.
Thank you, sir. And any particular choice of cooking oil which patiently routinely ask that what should I follow?
I guess if you saturated fat and take that have more fatty acids, they would be very helpful cutting down on the fat intake. That can dramatically reduce your triglycerides.
Thank you. Thank you, sir. Professor Sanjay Tyagi, sir, about the newer available pharmacotherapy, we have bempedoic acid freely available in the market and PCSK9 also available. So how do you place your patients according to these pharmacotherapy?
Yes. As the initial choice, the statins are the first drug that has to be used to reduce the LDL cholesterol level. Why? Not only reduce the LDL cholesterol level, they make the atheroma less prone to rupture. The endothelium that covers the plaque that becomes thick, and the chances of acute coronary reduces. Next drug, if we go into high intensity statin, and despite that, if the cholesterol level, LDL cholesterol level is not controlled, then as very and safe drug. It prevents the absorption of the cholesterol and from the intestinal gut. Then we have also used bempedoic acid very successfully and very few side effects. And these drugs also have the advantage that it has been shown that some of these statins may increase the chance of developing dyslipidemia. So they like azithromycin do not have this problem. They are now very easily available and less cost as compared to PCSK9 inhibitors, which we have for years now. They are very effective. Reduce the LDL cholesterol by 50%. So they are very effective, but they are costly drugs. Now we have good options which very fewer side effects. Statins, but still the statins remain the number one drug. Another thing that I want to add is that for triglycerides, now recent trials, the REDUCE-IT trial have shown that reduction of triglyceride by giving icotrokinra has reduces the triglyceride level and reduces the cardiovascular morbidity and mortality. What is it? The similar to like omega-3 fatty acids, salmon fish oil, these capsules are available and were available abroad for a long time. But in our country they are available and slightly costlier, but has been shown to reduce the morbidity and mortality and reduce the triglyceride level. So for triglyceride, after weight reduction, exercise, starting the statins, if the triglycerides still remain high, the icosapentine is the better drug than fenofibrate. Fenofibrate, the third option for, though it is easily available, but combination of statins with fenofibrate may produce these myopathy symptoms much more often. So another thing that I want to tell you is that after you start your patient on statins, do a CK level before starting statin, and then after 8 weeks do a CK level again to see if there is any rise in CK level, because many of these patients would complain of myopathy. Not know whether this is real myopathy, because in the social media there are many literature, many but my personal experience, these patients can be easily given high dose of statins and without any side effects. So it's a misconception that is going on in most of the social media that statins have their many side effects. They have very few side effects, and these side effects can be easily controlled. Another thing that apart from these type of statins is also very important. Now we have a drug like pitavastatin, which have been there but has not as frequently been used as compared to atorvastatin or rosuvastatin, but it is much safer option and has less of myopathy and less pro-diabetic. So this is another good statin that we have in those patients who have having these myopathy type of symptoms.
Thank you, sir. And the last question to Professor Sridhar Dwivedi, sir. So large number of these diabetics are going to develop CKD and having coexisting NAFLD and NAS, so going to have hepatic impairment. So what are the role of lipid-lowering therapy in patient having renal or hepatic impairment?
Very good question indeed. Patients who are having hepatic disease, chronic liver disease, in those cases, although statins have been proved to be not that contraindicated, relatively it is safe. You can use this. But there are certain conditions in which you will not use liver condition, like acute liver failure. Perhaps you would not like to use a statin. And always monitor your statin therapy, always monitor your therapy with the LFT, liver function test. See how much there has been change in AST level or ALT level. Sometimes if it is more than 3 times, then perhaps yes, you have to stop the statin therapy. That is one. Second thing about chronic liver disease, chronic kidney disease, CKD. In CKD also there is a dyslipidemia. CKD by itself also produces dyslipidemia. But there also the statins are safe. But in case the patient is heading for renal transplant or anything, then perhaps the statin is not the drug of the choice. In those cases where you are heading, patient is going for renal replacement therapy, then perhaps the statin should be used cautiously. This is the indication.
Any particular statin which you prefer in renal impaired patients?
Atorvastatin is equally good, but of course now the people are using more rosuvastatin.
Thank you. So I think we are gonna be wiser by the valuable insights of these wonderful eminent panelists with us. So I would like a comment from each of our chairpersons.
Our preeminent panel of specialists have given very erudite discourse on dyslipidemia, and they have left very little to doubt. But still, I would like to invite the audience for one or two questions.
Yes.
So, morning everybody. So at the end of the day, where do we exactly stand? So we are targeting these patients on statins, and what about the other triglycerides and triglyceride-rich proteins like the ApoB and non-HDL cholesterol? Whenever we are targeting with statins, what are we exactly dealing? Dealing with the LDL cholesterol. Once it is reduced, then where do we exactly stay now? So you are saying that whenever there is a risk of pancreatitis, then only you add all those along with this. What about those values between 150 and 500? Where do we right now stand? Should we go ahead, because majority of our products are marketed flooded with combinations of the statins and fenofibrate?
I guess that is what I was talking about. 150 to 500, the risk of pancreatitis is very low, but there is some residual risk even after you have a LDL of less than 55 achieved in your patients with previous cardiovascular disease or even primary prevention. 150 to 500 ADA guidelines suggest that you have to get down to 150. That is what I was talking about. There is a new concept of triglyceride by glucose ratio that they are demonstrating. Non-HDL cholesterol, yes, you have to get it down to less than 30 to have ACVD protection, but triglycerides are a good marker. Even after you have got a good LDL, triglycerides more than 150, you have to get it down to less than 150 so that you can reduce your cardiovascular risk. And when you have such safe drugs like a PPR alpha gamma co-agonist, I guess they are to be used more often, because these drugs would lower your triglycerides, they would decrease your NASH or MAFLD, that is the new term for NASH now. So the benefits are huge, these drugs, and even you have reduction of your fasting glucose with PPR alpha gamma co-agonist. So when you can have these multitude effects with these drugs that are very safe, you can get down to triglycerides in 150 very safely.
I think apart from the pharmacotherapy, the lifestyle modifications are a must in every case for diabetes. I simply use 2 or 3 aphorisms for any patient when he comes. Sakahar, the study which has been published recently that why the quality was less in Indian compared to, and they have come down to our food habits that have a lot role to play. Because they produce nutrogenomics changes inside the body. It's a very, I will request everyone here present here to read that. It is very recently published in Indian Journal of Medical Research. Because the food which contains in Indian houses, they contains many of the things which have a medicinal value, like clove, cardamom, turmeric, haldi, onion, lasun, all these have medicinal value. That it is said, food as a medicine, medicine as a food. It is your choice. So the choice is yours. So Sakahar, Sarvottam Ahar. Mota Ann, Sehat Sampan. Mota Ann, somebody had raised this question. Mota Ann, Sehat Sampan. Mota Ann, Sugar Bipan. If you take, because these mota and these coarse grains, they have low glycemic index, sugar pipan. So all these things are satyanas. This things during time. Now WHO has come recently, very recently, that in not any quantity of the alcohol is dangerous for health. It is associated with 7 types of the cancer. So all these small things have to be told to the patient, and we must educate and sensitize our patient, educate and sensitize ourselves also. So the previous speaker told very well that we have to sensitize ourselves also about the obesity. Motapa, dil ke liye syapa. Motapa, dil ke liye syapa. We have to sensitize ourselves and we have to sensitize our patients also, apart from pharmacotherapy, which we have discussed. Thank you.
Thank you so much. It's such a wonderful talk with all the panelists.
So what are your comments on the cognitive function effect of these statins on the cognitive function, especially in case of dementia patients?
Thank you for asking this important question, because it is frequently asked how low can we go to the LDL cholesterol level. For this, the important answer is that when a child is born, his LDL cholesterol level is around 25. So you can go as low as 25 with cognitive impairment. It has been shown in large studies that reduction of cholesterol up to 25, LDL cholesterol level up to 25 milligram per deciliter is safe. Below that is not required. So as low as possible, particularly in those patients with diabetes and coronary artery disease, go below 50. That is now what is recommended. Previously, in those patients with diabetes, any type of diabetes, give them statins, whether they have, even if their LDL cholesterol level is normal, even then you give statins because of the beneficial of the other risk factors. I said, they reduce the development of acute coronary syndrome. And as low as LDL cholesterol level would be better for the patient with diabetes. Those patients cannot get a single with a statin alone, give a combination therapy, as now commonly using in hypertension, similarly for dyslipidemia. Combination of statins drug, particularly like ezetimibe, is very safe and effective for lowering LDL cholesterol level further by 10 to 50%. So combine statins with ezetimibe in those patients who cannot be controlled.
Thank you so much. As the time constraint, would you like to speak? Okay.
I think with this we come to the end of this very productive and excellent session in which audience has also participated. I thank the honored panelists and my co-chairpersons. Thank you very much.
Thank you so much, sir. Now I will request our speaker, our panelist and our chairperson to reach the station area. And I will invite Dr. Ashok Grover to felicitate the panelists. For our next session, I would like to invite Dr. G.S. Bansal, Dr. N.K. Govil, Dr. Satish Gupta, Dr. Deepak Sharma, and Dr. Monica Mahajan. Kindly proceed to the stage, sir. Dr. G.S. Bansal is a senior consultant at Noida. Dr. N.K. Govil is a senior consultant at Dilshad Garden. Dr. Satish Gupta is working as a senior consultant at Mayur Vihar. Dr. Deepak Sharma is assistant professor at GIMS Noida. Dr. Monica Mahajan is director, internal medicine, MEC Saket. Kindly proceed to the desk. Our next speaker, Dr. Anupam Biswas, for Insulin in Diabetes 2 Management, Evolution over Time. Kindly proceed to the desk, sir.
We welcome all delegates to this session on insulin therapy. We have Dr. Anupam Biswas as the presenter. He is a MD in General Medicine and DM Endocrinology. Consultant endocrinologist at Fortis Hospital, Noida. Also a consultant Aditya Birla Memorial Hospital, Pune. He was the best. He got the best resident award during MD Medicine. He has been an assistant professor of AIMS, Raipur, and reviewer of IJM and Elsevier Journal of Diabetes and Metabolic Syndrome. He has many researched and indexed publications in national and international journals. He has membership of Endocrine Society of USA, ESI, ADA, IS, BMR, API, RSDI. I'll request Dr. Vishwas to present his lecture. Thank you.
So good morning once again, and first and foremost I would like to thank the organizers for giving me an opportunity to speak on this topic, how the insulins have evolved over a period of time and what are the latest guidelines when it comes to insulin in the management of diabetes. So the agenda is going to start with the history and discovery of insulin, and later I will go on to evolution of insulin, what the guidelines say, how to choose insulin, and what are the future insulins in store for us. So before the discovery of insulin, as we all know, the chance of death for a child diagnosed with type 1 diabetes was almost 100%. So this is the fantastic four of insulin discovery. So there's a small story to this. It was initially proposed by Dr. Frederick Brandt. He was a young orthopedic surgeon. He proposed this idea of a pancreatic extract to Dr. McLeod, who was the physiologist and considered as an authority on carbohydrate metabolism. So he provided him an assistant who was Charles Best, who was his student that time, and with the help of Charles Best and Collip, he led to the extraction of these pancreatic extracts and development of insulin. Although in the year 1934, two people, Banting and McLeod, were awarded the Nobel Prize for their discovery of insulin. Banting was not at all happy with this, and he shared his Nobel Prize with Best, and McLeod shared it later with Collip. So coming to glycemic control, as we have seen in most of our landmark trials, whether it is the UKPDS trial, the DCCT trial, or even the follow-up of the DCCT trial, which is the EDIC trial, that a good glycemic control matters. The initial glycemic control gives you a benefit even in the long run to prevent the development of micro and macrovascular complications. This is something which is known as the legacy effect in diabetes. Uncontrolled hypoglycemia demands timely treatment optimization and insulin initiation. But there is a huge amount of therapeutic inertia and stigma when it comes to initiation of insulin. So why insulins? Because as we all know, among all the anti-diabetic agents, insulin offers the maximum glycemic efficacy. There are also other pleiotropic benefits of insulin, apart from just reducing your blood glucose level. It also has anti-thrombotic, antioxidant and anti-inflammatory properties. And that is one reason why in critical conditions like diabetic foot or perioperative conditions, insulin is said to be the treatment of choice. So coming to what are the insulins which have evolved over a period of time, right from the isolation of insulin by Banting and Best to the animal insulin preparations which included porcine and bovine insulin, to the first intermediate acting insulin which was the NPH insulin. Later it moved on to the first generation basal insulin which includes Detamir and Glargine 100, and now you have something which is known as the second generation of basal insulins which includes Glargine 300 and Degludec. So these are the clinical features or the most commonly used insulins. The rapid acting insulins includes your Aspart, Lispro and Glulicin. The short acting is the regular insulin. You have the intermediate acting which is NPH, and long acting which are Detamir, Glargine and Degludec. Apart from that, you have premixed insulin and the co-formulation of Aspart and Degludec commonly available in the market. So coming to NPH insulin, why? Because this was the first available intermediate acting insulin with a slower onset and longer duration of action. However, there were challenges with NPH insulin. First, it had insufficient basal coverage and it needed for multiple injections. So you had to give it twice a day for basal coverage. There was a need for resuspension and significant day-to-day glycemic variability. So there were other methods to prolong insulin action which are used in Glargine, such as reducing solubility at physiological pH and acylation in Detamir and Degludec.
So these are the commonly used basal insulin and their properties. As you can see, the mechanism of prolonged duration of action in glargine includes precipitation at neutral pH in subcutaneous tissue, and deglutec, it is because of multi-hexamer chain formation in the subcutaneous tissue. You can see the duration of action is longest with deglutec in compared to detamid and glargine. However, there were unmet needs with the first generation of basal insulin also. They were not truly once daily. We have seen a lot of patients requiring twice a day glargine. They had higher glycemic variability, higher nocturnal hypoglycemia, and they were not truly peakless. And when we were managing diabetes, we have to take into various parameters into account, not just the glycemic triad of reducing your fasting, postprandial plasma glucose and HbA1c, but you should also take into account parameters such as nocturnal hypoglycemia, anytime hypoglycemia, and a very important parameter known as glycemic variability. So when you compare the two second generation of basal insulin, in most of the trials they have showed equal efficacy in comparison to the first generation basal insulin like glargine 100. But there were lesser risks of hypoglycemia with the second generation of basal insulin, which includes deglutec and glargine 300. There have been only two head-to-head trials between glargine 300 and deglutec with contrasting results. One of them showed superiority of deglutec, the other showed the superiority of glargine 300. But what should be remembered is that they provide similar glycemic control accompanied by comparable hypoglycemia. So they are more similar than different. However, a higher dose requirement is required with glargine 300 when you switch from glargine 100 or deglutec. So now coming to what are the latest guidelines, what they say. So the ADA 2023 states that if your glycemic targets are not met, you can start with a basal insulin. So you can start with 10 units per day or 0.1 to 0.2 units per kg per day. And choose evidence-based titration algorithm. Like you can increase every 2 to 4, 3 units, 2 units every 3 to 3 days to reach your fasting plasma glucose target without hypoglycemia. However, if the patient experiences any hypoglycemic event, try to determine the cause, and if no clear reason, you can lower the dose by 10 to 20%. So the choice of initiation of insulin by the ADA 2023 is a basal insulin if your glycemic targets are not met. And if with your basal insulin you're not achieving your glycemic target, it also gives an option of pre-mixed insulin, split mix regimen, or adding a prandial insulin and later go on full-fledged basal bolus insulin regimen. Why is it so? So the guidelines do suggest, because as we have read in all our textbook, to fix fasting first. Lower the fasting plasma glucose, it also helps you to lower the postprandial plasma glucose as well. But this may not be the situation in all the cases. Why? Because even the postprandial control of blood glucose is equally important. If you look at the Monier's hypothesis, it states that at an HbA1c of less than 7.3%, 70% of glycemic burden is contributed by the postprandial plasma glucose. When you have an HbA1c of greater than 9.3%, fasting blood plasma glucose contributes to the 70% glycemic burden in such cases. And an HbA1c of between 7.3 to 9.3%, it is equal contribution by both your fasting and postprandial plasma glucose. So it is very important not just to have a good glycemic control in terms of fasting plasma glucose, but also to have a good postprandial plasma glucose control also. And this is often we come across in our patients, I'm sure you would have also experienced. Patients may have a good, relatively good fasting plasma glucose, but their postprandial glucose are very high, providing a high HbA1c. So one reason could be a high carbohydrate carbohydrate diet, which is common in our Indian reality, which has been seen in most of the studies also. So 61 to 70% energy intake in Indians is through carbohydrates present in the diet. And this high carb diet can lead to a raise in postprandial glucose levels. So that is why if you look at the Endocrine Society of India and RSSDI guidelines, so this is a very important slide, and this gives you a basis of how to choose insulin. So you should remember among the basal insulin, whether it is NPH, glargine 100, glargine 300, detamir or digludec, all of them have equal efficacy, but the duration of action is longer with digludec in comparison to glargine 300 or glargine 100. NPH, detamir and glargine 100 may need to be given twice daily. Digludec and glargine cause least hypoglycemia with no tailing effects of hyperglycemia. Next, you have the pre-mixed regimen, which also have equal efficacy. But what is different? So you have this something which is known as IDEC aspart, which is a co-formulation of aspart and digludec. So why, although they have equal efficacy like pre-mixed insulin, there is slight difference. First, pre-mixed insulins are also intermediate acting insulins. So they may need to be given twice daily. Unlike a co-formulation where digludec is acting for more than 24 hours, it can be given once a day also. Moreover, it is preferred in patients who are coming with a relatively good fasting blood glucose but a very high postprandial plasma glucose. Thirdly, it avoids the shoulder effect. So what is this shoulder effect? So if you look at the pre-mixed insulin, they have a soluble component and one protaminated component. So what happens in such insulins? The protaminated component commonly interferes with the soluble component. And this interference can lead to a prolonged effect of the soluble component at around 4 to 6 hours, which is known as the shoulder effect in such premixed insulin. This shoulder effect is avoided in a co-formulation like aspart with digludec. So coming to glycemic parameters at insulin initiation, so you have to take into account various parameters like the BEAM value or the difference between your fasting and postprandial plasma glucose. BEAM is nothing but you calculate the bedtime blood glucose and your AM value. And if the difference is high, you can go for initiation with a pre-mixed insulin or a co-formulation in management of diabetes if your glycemic targets are not met with oral anti-diabetic agents. So IDEC aspart is the world's only co-formulation insulin. The two insulin components do not interact in the solution and in the subcutaneous tissue, thereby retaining their individual properties. Although co-formulations were tried with glargine and detamir also, but it did not get the satisfied results. Glargine, it is very tough to combine with other insulin because glargine has to be formulated in an acidic pH, whereas most of our short-acting analogs are at a pH of around 7.4, and glargine requires an acidic pH of 4.0. So that is one reason why glargine is not being able to co-formulate with other situations. Detamir, the problem was that it led to hybrid hexamer formation, which led to this delayed efficacy of the short-acting component, and because of which detamir also is not being able to combine with the other short-acting analogs. So till now we have only IDEC aspart with digludec. Early intensive insulin therapy for type 2 diabetes remission. So insulin is not just the last option. So even in patients who are coming or presenting with a very high HbA1c, during their first detection of diabetes, there is a high amount of gluco and lipotoxicity, so you can initiate insulin in such cases. Apart from that, insulin is also the treatment of choice in pregnancy and in diabetic foot. So short-term intensive insulin therapy improves beta cell function, which is commonly impaired in glucotoxicity. So now you have something which is known as the future of insulin. So you have coming up something which is known as icodec, which is once weekly insulin for type 2 diabetes in patients without previous insulin treatment. So icodec is once weekly basal insulin, and this was compared with glargine 100, and the time in range was greater with icodec in comparison to glargine 100. The best part was that the level 2 and level 3 hypoglycemic events were similar with glargine 100 and icodec. So there is another study going on, switching to once weekly icodec versus once daily insulin glargine, and probably we'll have the results soon. Last but not the least, efficacy and safety of oral basal insulin versus subcutaneous insulin glargine in type 2 diabetes. So oral insulin, also known as I-338, this is a long-acting basal insulin analog formulated in a tablet with the absorption enhancer sodium caprate. And this was investigated, and the efficacy and safety of I-338 was done against insulin glargine, which is the most commonly used basal insulin. So what was the results? I-338 provided improved glycemic controls in patients who had never taken insulin and with no evidence of a difference compared with insulin glargine, which is a widely used subcutaneous insulin. However, further development of this particular oral insulin project was discontinued because the I-338 doses were high, and therefore production of the required quantities for wide public use was deemed not commercially viable. So probably we are looking for more technologies involved in the product's development, which is the focus of ongoing research. Apart from that, Oramed has also recruited some patients with their oral and glucose sensitive insulin. Last but not the least, again you have evolution of continuous subcutaneous insulin infusion pumps, which has gone over a lot of changes from the first wearable pump, which was just like an army bag, to the newer devices which are very user friendly. The last slide is about smart insulin. What is smart insulin? It is a next generation insulin that automatically responds to changing blood glucose level. The lower or higher the blood glucose levels are, less or more insulin is released respectively. The insulin, whether taken as an injection or pill, keeps blood glucose levels normal throughout the day, and this eliminates not just hypoglycemia and hyperglycemia, but also multiple daily injections and the need for carb counting. So all smart insulin projects are at a very early stage, and in some cases, the drug is still being tested in animal studies. So why is insulin important? So this is the latest from the ICMR India B study, which was published in 2022, which goes on to show that only 36% of our diabetic patients are achieving a good glycemic control of an HbA1c less than 7%. So this goes on to say that the vast majority of our diabetic patients are not achieving a good glycemic control. So if you look at the ABC control, which includes your A1C, blood pressure, and cholesterol, only about 7 to 8% of our diabetic patients achieved a good ABC control. So coming to summary, insulin have been game changer over the last 100 years. Insulin have increased the life expectancy and improved the overall quality of life people with diabetes by providing a good glycemic control and reducing the risk of complications. So it is very crucial to facilitate its timely adoption, although it is considered a stigma and a failure in patients who start insulin, but it is not so. It is very important for us as physicians to counsel the patients that this is not a failure, but this would just bring about a change and improve their quality of life and prevent them from getting into the microvascular and macrovascular complications of diabetes. So insulin a right, not just a privilege. Thank you so much.
An excellent lecture, Dr. Bishwas. And the question that comes to mind is that in the Indian scenario, what is your determining factor for deciding which basal insulin? And secondly, where do you place the co-formulations again? Because the pre-mixed insulins are so easily available that which is your patient choice as far as co-formulations are concerned? So first, basal insulin choice. And second, in terms of which are the patients who rightfully deserve co-formulation?
Okay. So the first question is about basal insulin. So if a patient is coming with a very high HbA1c and there is not much difference between the fasting and postprandial plasma glucose level, suppose the fasting plasma glucose is around 300 and the postprandial plasma glucose is around 330 or 340. So this is the case where you start with a basal insulin. You can start with either of the basal insulin, and this should also take into consideration the cost and the economic background of the patient. because we have basal insulin which are very effective when it comes like glargine 100 or even biosimilars. But if a patient has comorbid conditions and more prone for hypoglycemia like CKD, or patients with chronic liver disease, or a very elderly patients, lean patients, so they may be more prone for hypoglycemias, you can also start with a basal insulin, a second generation basal insulin. Coming to the second question about pre-mix and co-formulation. So again, co-formulation, if you see, has to be taken, it can be started with just once a day. And if the difference between your fasting and postprandial plasma glucose is very high, more than 60 mg per dl, then you can start with a co-formulation or even a premix insulin, which can include your 50-50 preparation also, apart from the 30-70 preparation. Again, a lot of questions do come like whether you can give a co-formulation twice a day or not, because the long-acting portion is acting for almost more than 24 hours. You should remember that the long-acting component, even though it is acting for more than 24 hours, there is no insulin stacking of long-acting insulin. Secondly, it can be given twice a day, and if the doses are same, there is just a difference between the peak to trough ratio, but apart from that, there is not much difference. And once it has reached a steady state after 3 days, it will remain at the same level no matter what doses you give, so there are lesser chances of hypoglycemia.
Any questions from the audience?
These days, and all the corporate hospitals are endorsing to it. Now, the 36% which you are saying the glycemic control, will it improve with all those biosimilars which we are normally using these days? And how different are they from the parent molecule in terms of our experience? Because we have been prescribing it for now almost a year.
So in my experience, biosimilars are also doing the job. We are prescribing it regularly in our hospitals, and they are equally equivalent when it comes to glycemic efficacy in comparison to the basal insulins which we are using. Although we have seen for reducing the this percentage, it is not just the hospitalized patient, but even our OPD patients also who are not taking their tablets on time or oral compliance or not following up with their doctor visits regularly. So that is also an important part apart from just IPD patients. I think the biosimilar session also has spoken a lot about the bioequivalent and biosimilar. And in fact, bio-betters also now in the pipeline.
In US, maybe there's a big difference in the cost of biosimilars and the patent molecules. But India, somehow we are not getting that advantage. The difference between the Lantus and the Vasaglar, I think, is not even 100 rupees. So if these biosimilars are manufactured in India and they exported to US, I think the companies should do something that we should actually get, our patients should get that advantage of cost that we are talking so much about. In the session also we talked about it, and now also we are discussing it, but actually it is not there in the real life, it is not there. And one comment about co-formulation and basal insulin. I think if we reach the maximum level of, let's say, 60 units per day of any basal insulin, then we should start thinking about adding a prandial component, and the co-formulation would be a very good choice for that. Thank you.
Just a quick comment on the choice of basal insulins. I think one of the factors that you can think of while choosing a basal insulin is, as you said, comorbidities, and you said comorbidities, you prefer the second generation of basal insulins. But I think chronic liver disease is one condition where you would rather not have, because of the hypoalbuminemia, you may not like to choose degludec, you may like to choose glargine in those cases. Yeah.
There are no questions. We can conclude the session. Thank you, Dr. Biswas.
Thank you so much for such a wonderful talk. Now I will ask our speakers and our chairpersons to kindly reach the felicitation area. And I will invite Dr. K.D. Kautalya, a senior consultant from Noida, to felicitate the speakers and the chairpersons. moving towards our next session, Target Kidney Protection from Day 1, I would like to invite the chairpersons, Dr. Amit Gupta, Dr. S. Chakrabarti, Dr. Tarun Goyal, Dr. Akansha Singh. Kindly proceed to the desk, sir. Dr. Amit Gupta is a senior consultant nephrologist at the Max Vaishali. Dr. Akansha Singh is assistant professor at ABV IMS and Dr. RML Hospital. Dr. Sebil Chakravarti is additional professor internal medicine at ESI Medical College, Faridabad. Dr. Tarun Goyal is a senior consultant at Max Hospital, Vaishali. And Dr. Rajiv Chawla is a senior diabetologist at Jaipur. Now I would like to invite our speaker, Dr. Rajiv Chawla, on the stage.
Good morning, and I welcome to you all this part of the CME. So gone are the days when we used to prescribe the antihypertensive agent just based on the absolute numerical values. So these days, with the introduction of various cardiovascular and renal outcome trials, we are more wiser to have an early end organ protection. We definitely would like to save the organs till the end as much as possible. To speak about the same, we have none other than our most esteemed Dr. Rajiv Chawla with us. Dr. Rajiv Chawla, if I go on reading the whole CV, it's quite big, and I would not waste time. We would like to listen to him. Over to you, sir.
Good morning, everyone. Thanks for those kind words. At the outset, I am extremely thankful to my friends, Professor Amitesh and Dr. Ajay and entire team of LeadCon for this opportunity. Well, this is my disclaimer. It is a sponsored session. So what I am going to do is to take you through a small session of 15 minutes, target kidney protection from day 1 in diabetes patient, whether it matters. It's an Astra-sponsored session. Let me give you a prototype case. A 52-year-old male who has hypertension and diabetes for 5 years. His HbA1c is 8. His BMI is quite high as per Asian and Indian criteria. It is 27. His blood pressure is high. He is already on telmisartan. Blood pressure is 142/90. His eGFR is 59. So he straightway falls into the category of CKD. His cholesterols are very bad. LDL 158 against optional 70. And he's already on metformin, telmisartan, and rosuvastatin. Unfortunately, we don't have any information on his urine albumin creatinine ratio, whether it has been measured or no. And let me tell you why we are talking, why I'm saying that unfortunately we have no information on urine albumin creatinine ratio when we already know the eGFR is 58 or 59. Is it important today to do urine albumin creatinine ratio and then put it into the KDIGO guidelines and that matrix and see what is going to be the prognosis? So having said that, we know CKD in India is very, very common. Prevalence is close to 17% in adult population, but unfortunately it comes as a very, very late diagnosis. There are almost more than 2 lakh patients already on hemodialysis with just 5,000 centers doing that services. And if you see the distribution by age, by stage of CKD, most of your patients, around 50% they have CKD stage 1, and remaining 50% they are distributed between stage 2, 3, and 4, and 5. But what I said, unfortunately, most of the time diagnosis comes very, very late. So about 40 or 50% patient will get diagnosed for the first time when they are already into stage 3, 4, or maybe end stage renal disease. So stage 3 CKD is highly very prevalent. I'm sure we all know what is stage 1. It is hyperfiltration. Stage 2 clinically cannot be assessed or cannot be monitored. Stage 3 is when it is only the presence of microalbuminuria, and then stage 3B, macroalbuminuria. Today we are talking about GFR, G1, G2, 3, G4, 5, and albumin 1, 2, and 3 as per KDIGO guidelines. So CKD stage 3 is very, very important. it is quite prevalent and significantly, unfortunately, underdiagnosed even in high-risk patients. Because otherwise it should be the best opportunity to intervene, because if you can still pick up the patient at stage 3A and intervene not only in terms of glycemic control but also with ACE and ARBs and couple of other drugs, probably you can reduce the progression of CKD towards end-stage renal disease. But unfortunately, stage 3 CKDs, 96% patients are undiagnosed. That is not in routine diabetes practice. KDIGO says that ideally all patients for CKD, at least in high risk, should be assessed whether they have hypertension, diabetes or CVD, but significant rates of undiagnosed CKD stage 3 still exist even in these high risk groups. Reveal CKD study said that 27,000 patients, which is the data from US TriNet X database, they were evaluated and EGFR declined before and after CKD diagnosis was different. That is why we are very, very particular. We say that we must pick up every type 2 diabetes patient right at the time of diagnosis, first visit at onset, and we must look for presence of microangiopathy, more so for microalbuminuria, maybe a foot examination and a fundal examination, so that we can check the progression of the disease, because if you pick them early, probably you can do a lot of wonders in terms of regression or in terms of halting the progression towards end-stage renal disease, because before diagnosis and after the diagnosis, your approach will change and you will put not only good glycemic control, but couple of the drugs. So this patient who has EGFR 59 ml, and if we are not getting any information on albumin creatinine ratio, probably we will not be able to assess the overall risk in this patient, because this patient, if we are not sure about the albuminuria, we may say that there is no albuminuria, or we are silent on that. EGFR is already 59, so may not have very high risk towards end-stage renal disease and towards CVD, because this is falling into the category of A1. Although there is already EGFR reduction, it is category G3A. But moment you have an information on presence of albuminuria in the same patient, say it is 200 milligram, it's an hypothetical situation, albumin is already 200 milligram per gram of creatinine, so obviously this patient will straightway fall into the category of moderately increased risk. And believe me, someone who has EGFR 59 at the end of 5 years of diabetes is not very unlikely that many of these patients might have even gross proteinuria more than 300 milligram on daily basis, and straightway this patient will fall into the category of A3. So then you can classify that risk for CVD, end-stage renal disease, and progression is going to be extremely high. So that is what is the importance of doing not only an EGFR in clinical practice, but also looking into the albumin creatinine ratio, because our entire treatment approach is going to change based on the presence of albuminuria or absence of microalbuminuria. So 2022 KDIGO guidelines straightway gives you an algorithm that if patient has type 2 diabetes with CKD, even if it is stage 3A, presence of microalbuminuria, lifestyle modification has to be part of every therapy, starting from increased physical activity of 45 minutes per day basis, good nutrition, a balanced diet. I am not going to talk about salt restriction or protein restriction, especially in Indian and vegetarian patient, because even 0.8 gram per daily basis protein per kg does not happen in vegetarian patient. But it is important, if patient is obese, an attempt to weight loss has to be there. Obviously the first line option today, if I talk about our own RSSDI wheel or ACE or ADA guidelines, is that we may start with metformin. Now, well, there are organizations like ACE 22 and 23 said that if you have presence of albuminuria, diabetic nephropathy, reduction in EGFR, or reduce ejection fraction, straightway you may start with drugs like GLP-1 receptor agonist or SGLT2 inhibitor even before metformin. But our own 2022 guideline recently released, we said that metformin still remains the core therapy in every patient with type 2 diabetes until unless there are contraindications to metformin therapy. So metformin safely can be continued till EGFR is 30. Of course, between 30 to 45, moment it is less than 45, we need to reduce the dose by 50%. After 30, we need to discontinue metformin, or anyone who's going for hemodialysis, we'll have to discontinue metformin. SGLT2 inhibitor, fortunately, now we have a cutoff that you can continue till EGFR 20, because we are wise from DEPA CKD and EMPA kidney trial that lower the EGFR, still the benefits, not glycemic, but extra glycemic benefits and renal composite benefits are going to last, rather benefits may be much more at a reduced EGFR. So we like to continue with SGLT2 inhibitor plus minus metformin till EGFR is less than 20. For getting good glycemic control, additional drugs ideally could be a GLP-1 receptor agonist, because it has benefits in terms of albuminuria reduction, 3-point MACE reduction, but then all guidelines say that we have to be guided by patient preferences, comorbidities, EGFR, and most important thing in Indian scenario is the cost. That is why in our we say ABCDFGH approach, where F is the financial constraint. Not every patient will be able to afford an injectable or for that matter an oral GLP-1 receptor agonist. There we could choose drugs like DPP-4, sulfonylurea, smart sulfonylureas are available, AGIs, even TZs also, as long as we are able to get a good glycemic control, minus the contraindication to each drug. I'll not have time to discuss that. ADA standards of care, again, treatment of patient with type 2 diabetes with CKD, that means already there is a reduction in EGFR less than 60 or presence of albuminuria more than 200 milligram per gram of creatinine. First line option obviously becomes SGLT2 inhibitor. These are the preferred class of drugs which must be used irrespective of the baseline A1C, irrespective of the A1C target. Even if patient is already maintaining an HbA1c close to 7, it is better you reduce other drug, make a space for using SGLT2 inhibitor, or maybe remove other drugs and add SGLT2 inhibitor, because renal composite endpoints are going to be down significantly. So the preferred drug is going to be SGLT2 inhibitor with primary evidence of reducing CKD progression, or SGLT2 with primary evidence of reducing CKD progression in all CV outcomes, whether it was EMPA-REG trial, DECLARE TIMI, CANVAS trials and other trials, or add GLP-1 either in combination with SGLT2 inhibitor for good glycemic control and other benefits, or it may be vice versa. Patient is already on GLP-1 receptor agonist and you may add SGLT2 inhibitor. If EGFR is already less than 60, it is already G3, but there is no albuminuria, again preferred drugs are going to be SGLT2 inhibitor. It will obviously score over GLP-1 receptor agonist because there is a proven evidence with SGLT2 inhibitor in terms of renal composite endpoints going significantly down by almost 30 to 40% in individual trials. So which SGLT to choose from? Let me take you the DECLARE TIMI 58 trial with DAPA, which represents the population seen in general practice. What you see in a garden variety of patient, only on an average 20% patient will have established atherosclerotic cardiovascular disease or events. In primary practice, 75% patient may not have, only they might have only multiple risk factors. So if you talk about EMPA-REG outcome, it was primarily a secondary prevention trial because all 99% patient had evidence of atherosclerotic cardiovascular disease and EGFR was more than 30. CANVAS included 2/3 patient, those who had established atherosclerotic cardiovascular disease event, and DECLARE TIMI had only 40% and 60% patient had multiple risk factors. So it is very, very close to our clinical practice or primary care practice, where we know maybe 70% patient may not have established atherosclerotic cardiovascular disease and there could be only a clustering of risk factor. So let me take you to DAPA data in type 2 diabetes patient. Well, this was when it was launched about 7 years ago. We knew that irrespective of the baseline HbA1c, higher is the baseline HbA1c, greater is HbA1c reduction. It could be 1.32 if baseline HbA1c is 9.4. Otherwise, you'll get at least 0.8% reduction in HbA1c. It could be combined to metformin, to sulfonylurea, to DPP-4, even to insulins or combination of sulfonylurea and metformin. Higher was the weight, greater was the weight reduction. So if BMI is close to 35, obviously you may get around 3 kg weight loss. Even if BMI is close to 23, what is a typical Indian scenario, our patient may not be very, very obese. 23 to 25 is already overweight. There also you will get at least 2.5 kg weight gain. And Weber study said that in hypertension, uncontrolled hypertension with type 2 diabetes, there is going to be additional reduction in blood pressure, which could be 10 millimeter versus placebo, because lifestyle modification, everything is going on even in the control arm. So there it may be only 7.3. So you additionally get at least roughly 4 millimeter by 2 millimeter diastolic reduction, which is something like adding a drug like ramipril 2.5 milligram. So that is an advantage of adding an SGLT2 inhibitor. 52 weeks data has shown that HbA1c reduction was versus glipizide was 0.52. It was comparable, and there was a reduction in body weight versus placebo corrected. It was 4.4 kg, and 4 years data has shown, I told you, a reduction in blood pressure by 4/2 with almost 10 times lower incidence of hypoglycemia. So DAPA has shown that it could be used as a preventive as well as a therapeutic drug for management of cardio-renal disease in type 2 diabetes. These days we talk about care me approach, cardio-renal metabolic approach, where not only you want to reduce the prevalence and further progression of NASH and NAFLD diabetes, you want to cut down on weight, you want to cut down on blood pressure, you want to cut down on cardio-renal progression. So there, if you intervene early, before the onset of the disease, even with multiple CV risk factors already there, this could be used as a drug for primary prevention. But if you already have a cardio-renal event or a repeat cardio-renal event, there obviously this is going to be a therapeutic window for reducing the progression of cardio-renal disease in these patients. So DAPA slowed renal disease progression in type 2 diabetes with relatively good baseline renal function, because in this mean EGFR was 85. That is why it said it is almost something like close to a primary clinical practice. Canvas had 76 and EMPIRIC had 74, but there was a significant reduction in renal composite endpoint by almost 33%. And mind it, that renal benefits were demonstrated across EGFR groups, whether it was 30, whether it was between 60 to 90 or more than 90, and all the benefits were there, even in the group whether there was a presence of atherosclerotic cardiovascular disease or no presence of atherosclerotic cardiovascular disease, only multiple risk factors. So deterioration of albumin category also was seen, and it was seen as compared to the baseline. If patient is on DAPA, obviously there is going to be a reduction in albuminuria progression, and some patients have also shown regression from macro to micro and towards normal albuminuria. So that means even if you have presence of already microalbuminuria or macroalbuminuria more than 300 milligram, there also you are going to get and harvest all the benefits. And in terms of CV safety and other side effects, it was almost like placebo. So this is by Subodh Verma, a beautiful cartoon, a depiction, a hypothesis that these days when we are talking about pump, pipes and filter, DAPA probably covers it all. For all those patients, those who had established atherosclerotic cardiovascular disease and declared TME, which was a population close to 40%, certain patients already had acute MI. In last 2 years, they had the maximum benefit in terms of 3-point MACE reduction. So if you have prior MI benefits in terms of 3-point MACE reduction or CV death, combined with hospitalization with heart failure are there, but renal benefits could be seen even with multiple risk factors, whether there was a significant reduction in EGFR, presence of gross proteinuria or microalbuminuria, or just for primary prevention, the renal benefits were almost alike. So this should be viewed as an opportunity to intervene early so as to check the progression of diabetic kidney disease. And DAPA-CKD, which has been stopped before time because of overwhelming response, what was seen irrespective whether you are diabetic or non-diabetic, if your EGFR was between 25 to 75 and you had a proteinuria between 200 to 5,000 milligram, that means 5 gram, and you were already on ACE or ARB, stable doses, still if you add DAPA there as 10 milligram versus the placebo arm, not only there is a reduction in primary endpoint, which were renal composite endpoints, by 39%, and number needed to treat were only 19. So it was a very, very significant positive trial. All-cause mortality came down by 31%, and even CV death and hospitalization for heart failure also came down by 22%. So today, DAPA is a very clear option. It's a one step ahead, just finishing last slide, in cardio-renal protection, with not only getting a powerful glycemic control, new onset of diabetes in pre-diabetes or non-diabetic population also could be delayed. There is going to be reduction in CVD and hospitalization, heart failure combined together. Mind it, this was a composite endpoint by 29%, all-cause mortality went down by 31%, hospitalization and primary prevention significantly down. It has been seen as a class effect in all SGLT2 by 35%, and CV death in hospitalization with reduced ejection fraction with or without type 2 diabetes by again 20%. Just a last slide, because there is a discussion on biosimilar in the previous session also, but mind it, this being I won't be biased for a drug that you cannot use a biosimilar. Let me put it very, very straightforward. But we must see that a pharmaceutical equivalence by PKPD could be said as a bioequivalence, but whether it will translate into terms of therapeutic equivalence is a question mark, because we don't have any CV outcomes. So let those patients, those who can afford a innovator drug, SGLT2 like DEPA, be on a innovator drug. But if someone who cannot afford it, obviously those patients should not be denied the option being on dapagliflozin, and they could be given any of these generic DAPAs which are available. But there is a difference in terms of chemistry also. Original DAPA, which is Foxiga, is a crystalline product, and it is a propranolol monohydrate, while other DAPAs, we are not very sure whether they are amorphous or crystalline. So we must intervene early so as to check the progression of not only cardio but renal progression in these patients, and this is what was done in this patient. And toward the end, this patient was categorized as 3A with albumin 2 urea, so the DAPA was the best option in this patient. Thank you very much for your patience listening.
Thank you, sir.
Sorry,
Thank you
I
very
took
much for
about
your
a minute
overview.
more. It was just 15 minutes, so yeah.
So where do we exactly stand with mineralocorticoid antagonist as an early end organ?
Definitely. MRA these days, Ceneron is already available, but there are, and we are wiser from both the trials, Fiagro and Fildero, that these could do wonders in all those patients, those who are already on ACE, ARB, maybe already on ARNI, SGLT2 inhibitor, and fifth pillar could be adding an MRA to check the progression of CKD in these patients. But first thing is the glycemic control, most important thing. SGLT2 inhibitor, irrespective whether patient is diabetic or a non-diabetic, because 55% patient even in DAPA CKD were non-diabetic, 54%, they must be on SGLT2 inhibitor, ACE or ARB, until unless there are contraindication to that, and MRA today, which could be an additional drug to check the progression of renal endpoints.
So the issue is early end organ protection. Do we
Pardon?
have, the main issue is early end organ protection.
Yeah.
Okay. So do we have any other markers where we can screen or identify, like cystatin C or lipoproteins or something like this?
See, at the
Early-
time of diagnosis, possibly only
USCR
screening
is the
clinical
only-
is microalbuminuria, a fundus for microangiopathy, maybe a foot examination, a baseline ECG, and if needed a 2D echo. But as you want to check the progression of the disease, over the years you want to follow these patients of type 2, I am straightway saying, because type 1 is a different story. There everything has a very linear relationship. Type 2 is much more heterogeneous as compared to type 1. Of course, lipid profile, statin for every patient, aspirin, Servil, primary prevention, again it is out, secondary prevention aspirin, ACE, ARB, moment you have presence of albuminuria, and you can check the progression with only microalbuminuria in clinical practice. All other markers are, biochemical markers are available, but they are not in clinical practice. We recently published 2 data last year, one in primary care and general diabetology. We said that cortical renal length and overall kidney length and the corticomedullary, that differentiation can be a predictor of early diabetic nephropathy. Recently we finished another study. We said, and this we presented this year in ACE and got published in endocrine practice. We said resistive index as measured from a renal Doppler by a top trained radiologist, single subjective examination by a trained radiologist can take you to the diagnosis of progression of diabetic nephropathy much earlier than microalbuminuria and other things. But those are all research tools. Not in every patient you may ask RI as a marker of progression of diabetic nephropathy, but these are already available as research tools, or maybe certain group of patient to say that whether patient is progressing well, and it may come much earlier than increase in creatinine or even fall in EGFR. These were 2 studies, those are already published, where we said that progression of microangiopathy by looking for these markers can be a fact in long-term practice.
Thank you, sir, for this
Thank you.
nice presentation.
Thank you very much. Thanks a lot, sir.
Any questions from the audience? Thank you, sir.
Thank you.
Thank you so much, sir, for such a detailed speak. Now I would like to invite Dr. P.N. Chaudhary to felicitate the speakers and the chairpersons at the felicitation area. Kindly proceed.
So continuing the session further, I would now request the chairpersons for the next session to come to the stage and be seated. Dr. Amit Sharma, Professor of Medicine at Lady Hardinge Medical College. Dr. Vinod Chaitanya, Professor of Medicine, Safdarjung Hospital. And Dr. Harmeet Singh, Consultant and Head Emergency Medicine at Fortis Hospital, Gurgaon. The chairpersons to please come up to the stage and be seated. I would now like to request the speaker for this session, Dr. Rupen Gupta, Senior Director Cardiology, Max Hospital, to the dais.
Good morning, everyone. Now, next session is by Dr. Rupen Gupta. He is going to speak about early and appropriate CV risk reduction by beta blockers and the statins. Sir is Senior Director Cardiology, Max Saket, New Delhi. I welcome you, sir.
Thank you. I thank the organizer for inviting me for the talk. Basically, I'm talking on very common things. We are talking about beta blockers, we are talking of statins, how they help. So I'll be taking a representative example of a diabetic patient, and we'll see how we place these molecules. You see, there's a lot of controversy in usage of statins for primary prevention. Statins for secondary prevention, there is no doubt we have to give. But primary prevention, where to place? Let's say a young male comes to us with an LDL of 155. Should we straightway start him on a statin if he has no other risk factors? Similarly, beta blockers, they have a very definite role in heart failure, arrhythmias, post-MI setting. But as an antihypertensive molecule, we say that all the guidelines say that beta blockers should not be used as a first-line drug. But what happens is that if we see the patient profile, ultimately, in my prescription at least, I see that 1/3 of my patients ultimately land up in beta blockers. So it is not like we can throw the beta blockers out and say that all our patients will be on a ARB and a CCB or a diuretic. But a lot of patients have some other issues which make me put them on a beta blocker. So I'll be talking on these two things. What is the role of statins in primary prevention, in which groups we should prefer, how to choose, and what is the role of beta blockers in our clinical practice, leaving aside heart failure and other important subsets which we know where beta blockers definitely are a class 1 indication. So we take a representative example of a 42 years male patient. He is a diabetic. His family history of diabetes is there. He is hypertensive also. He is already on anti-diabetic medications. He is on dapagliflozin and metformin, and also started on telmisartan for his blood pressure control. Still the BP remains on a higher side. It is 150/90. Pulse rate is high. This is a typical thing which we see in our young Indian patients. We have a higher pulse rate, and they all sometimes come in a palpitation also. So this patient needs a better blood pressure control. Along with that, his LDL is remaining on the higher side. It is more than 130. 6 months back also it was high. Now it is also on the higher side. So should we do something for this dyslipidemia? He's a young male, and once we start him on statins, we are thinking of putting him on statin for the next 30-40 years. So what are the evidence to give a statin for such a long time in a young patient? So I think these are two discussion points which comes in my mind for this case. This is a very important slide which shows that in a patient who is diabetic, the majority of the cardiovascular risk reduction will come through control of LDL. So 70% of his cardiovascular risk reduction will be through LDL control, not by better diabetic control or better blood pressure control. So they are important, but the most important aspect is LDL control. So that is also reflected in the guidelines. I'll be coming to the guidelines where they say that in a diabetic patient, LDL control is very, very important. And if we look at the Indian scenario, we see that majority of our patients are diabetic patients are having dyslipidemia, but we achieve the goal in only less than half the patients. So we need to be more aggressive in treating our diabetic patients for dyslipidemia. Similarly, if we take our hypertensive patients, around 60% of the Indian hypertensive patients are having a sympathetic overactivity, and some other factors like diabetes, smoking, obesity, stress, they can also lead to more of sympathetic overactivity, and in these patients, giving a beta blocker is not a bad choice. And if you look at the post-MI, clearly in a post-MI setting, we know beta blockers have a definite role. So they lead to a reduction in all-cause mortality, sudden death, non-fatal MI. So in this patient, let's say how to decide about the statin. So when I see a patient who is not a heart patient, and we want to decide about his statin use, number one, we should look at the baseline LDL value. But this is not the most important factor. We should look at the age of the patient, the comorbid conditions, especially if the patient is having diabetes or chronic kidney disease. And also, if the patient is having no other major risk factors, then we should assess the 10-year risk of atherosclerotic cardiovascular disease for this patient using the various scores which are available. Now, if the patient, and broadly we can divide the patient into 3 categories. If the patient baseline LDL is more than 190, he should be on statins. Patient is 40 to 75 years of age and he's a diabetic, he should be on statin. Patient has a 10-year risk of ASCVD more than 7.5%, he should be on a statin. If the LDL is more than 70. So if the LDL is less than 70, then this patient does not need to be on a statin. But if the LDL is more than 70, then he should be on a statin. This is very, very oversimplification of the guidelines. But if we should have a basic framework in mind when we are trying to decide statin in a primary prevention scenario. And when we have want to choose the statin, so which statin to choose? Should we give atorvastatin? Should we give rosuvastatin? This is another question which comes to the mind. And we have a lot of data for both, and all the guidelines say that you can choose either of the 2 statins. There is not much to differentiate between the 2. But in the next few slides, I'll show some advantages or disadvantages between the 2 statins. But guidelines are very clear that our aim is to lower the LDL levels, and we can use atorvastatin or rosuvastatin with the dosage of, let's say, if we're giving 10 mg of rosuvastatin, then the atorvastatin dose should be 20 mg. But in few trials, like in Uranus study, in primary prevention patients, they saw that the rosuvastatin was more effective in lowering the LDL values as compared to atorvastatin. Also in Stellar trial, it was seen that 10 mg of rosuvastatin was more effective than 20 mg of atorvastatin in reducing LDL cholesterol. So clearly, rosuvastatin is a more potent molecule. There is no doubt about that. This is a Jupiter trial which was done in patients more than 50 years, male patient, and more than 60 years female patients, where the LDL was less than 130, but the CRP was elevated, and they were trying to see whether the elevated CRP levels, if we reduce them, will the patient benefit? Clearly, they saw a very good reduction in LDL, 50% reduction in LDL levels, with a 37% reduction in CRP levels. And there was good reduction in MI, stroke, unstable angina, non-fatal MI. But the major criticism of the trial is that the absolute number, risk reduction was very small. So clearly this tells us a good thing that we should be using statins for high-risk patients. If we use a very low-risk subgroup of patients, the benefit will come, but that will be relative reduction. In this, the total endpoint reduction was only 0.7%. And the cost of therapy for 1 year to prevent one event was something like $700,000 US in, if we take it in US prices. So clearly, statin should not be used in low-risk patients. This is the main, that's why I presented the Jupiter trial, to emphasize this point that in low-risk patient, the benefit will be less. But if we take a patient who is moderate risk or high risk, then the use of statin in a primary prevention scenario will be much, much higher. What are the guidelines say? We take the ESC guidelines, which clearly tell us that if a patient has a documented ASCVD, which means patient already has a myocardial infarction or he has a blockage in the heart arteries, even on a CT angiography, he'll be classified as a very high risk group. Or he's a diabetic with target organ damage, or diabetes with more than 3 risk factors, or a long-standing type 1 diabetes, severe chronic kidney disease, or if the score, which is a 10-year risk for ASCVD, is more than 10%, then this is a patient where he's a very high risk and we should target a LDL of less than 55. Now we come to another subgroup of patients which are less severely diseased, like diabetes, but without any target organ damage, or diabetes which is more than 10-year duration, LDL level which is more than 190, or patient has a total cholesterol more than 310, or patient is hypertensive with a BP of 180, 110, moderate CKD. So in this patient, or a score of between 5 to 10%, in this we should target LDL of less than 70. And then moderate risk patients are where young patients with type 2 diabetes mellitus, like less than 50 years of age with type 2 diabetes mellitus, or diabetes less than 10 years of duration, or the calculated score is more than 1% and less than 5%. In this we can target a LDL of 100. So clearly the LDL target and the dose of the medication we have to give changes with the baseline profile of the patient. Here you have to see that it is not the LDL value itself which is important. There are other factors which are important. So we have to assess the patient globally when we are trying to start a statin in a young patient or in a patient who doesn't have a coronary artery disease. And another point to be considered is that when we intensify the statin, first we should increase the dose of statin rather than adding ezetimibe. So ezetimibe should be only added once we have reached the maximum dose of the statin we are giving, like that is 80 mg for atorvastatin or 40 mg for rosuvastatin, or unless the patient is not able to tolerate this maximum dose. Let's say patient after 20 mg is having some side effects due to statin, then we can add ezetimibe beforehand. Otherwise, we should first try to increase the statin. Our strategy should not be that after giving 10 mg of rosuvastatin and next step is to add ezetimibe. We should, if the LDL goal is not achieved, we should go to 20 mg of rosuvastatin first. And if the patient tolerates it, that is the first line of therapy. And if still the goal is not achieved, we go 40 mg. And not add ezetimibe. Ezetimibe should be added as a last resort if the patient is not maintaining the goal or he is having significant side effects. Now, ADA guidelines are also very clear. They say that if the diabetes patient with age 40 to 75 years, moderate intensity statin should be given. If the age is less than 40 years of age, then he has to have some cardiovascular risk factors to initiate a statin therapy in this patient. So young diabetics straightaway should not be given a statin if the LDL levels are very moderate levels, not very high levels. Or a patient who is a diabetes with very high risk, especially multiple atherosclerotic cardiovascular risk factors, this is the patient where high intensity statin should be given. So if we compare safety of rosuvastatin versus atorvastatin, there are few advantages of rosuvastatin. Now, atorvastatin is a lipophilic molecule, and it is metabolized in the liver, and it uses a enzyme CYP3A4, which has a lot of drug and food interactions, while rosuvastatin is a hydrophilic molecule, and it uses a different pathway. And it has a hepatic and renal excretion also. So clearly, in patients where multiple drugs are going on or food interactions are a problem, then we should be preferring rosuvastatin. Especially grapefruit is one which increases the level of atorvastatin in the blood. So clearly, if the patient is taking a lot of grapefruit, then atorvastatin is not a preferred agent. Rosuvastatin should be used in this subgroup of patients. Only thing is that if the patient is having a kidney issue, then I will be preferring atorvastatin because it has no renal excretion. So in a patient with renal dysfunction, my preferred choice will be rosuvastatin. And rosuvastatin also has been shown to be effective in having less muscle side effects in one of the studies. If we look at the innovator, that is the Crestor brand which is available versus the generics. So generics have some problems, like in one study it was shown that atorvastatin, which is available in the market, generic, has a lot of methylated impurities, and this can translate into reduced efficacy. In one study where innovator molecule was compared with generic statins, it was seen that generic statins were not as effective. So clearly innovator molecule should be preferred. And if we take a look at the elevated heart rate management, so beta blockers have a lot of role because they lower the heart rate, so they lower the myocardial ischemia, and they lead to delay the progression of CHD. Now, if we look at the molecules, metoprolol is a preferred agent because it lowers the heart rate by around 15 beats per minute. It is absorbed from gut, and it has a hepatic route of excretion and no active metabolites. And in one study, it was shown that in hypertensive patients with sympathetic overactivity, it led to a all-cause death reduction and sudden cardiac death reduction. If we look at the specific molecule from AstraZeneca, that is Selocaine, it has consistent 24-hour action. And because of that action, the less side effects are there, no food interaction, and there is a better tolerability. And this specific molecule, if we compare with bisoprolol, we see that the plasma levels are maintained better over 24-hour period. Clearly, it proves more efficacious. And also, we know that Selocaine, which is a metoprolol agent, has more indication than bisoprolol, especially for post-MI setting and cardiac arrhythmias. So this is my last slide. So statins have a proven role in primary prevention, but should be given not only based on LDL value. So this is, I think, the most important thing we should remember, but we should assess the global risk assessment of the patient. Rosuvastatin is more efficacious than atorvastatin with fewer drug and food interaction, but to me, both molecules are very good and can be used interchangeably. In few indications, I may be preferring rosuvastatin or atorvastatin between the two. And beta blockers have a definite role for cardiovascular risk reduction in young hypertensive with sympathetic overactivity, besides their role in heart failure and post-MI settings. Thank you.
Thank you, Dr. Gupta, for such a nice and excellent talk. I have a small question. Since long we are using statins and beta blockers. So is there any side effect of using statins, long-term side effects?
You see, if we are using statins, now we know that they can cause muscle issues, so we are doing liver impairment, so we are regularly checking for those things. Let's say a patient comes to us, we initiate a statin, we'll be looking at our LFTs maybe in the next time when he visits our OPD. So I think long-term statins are safe. So that is one thing we have to clearly understand. In majority of the patients, they are a safe option and to be given for long-term. Only thing is that before we initiate a statin, we should know that this is a patient who actually requires a statin. Because once we start, we should not stop. So lifestyle modification should be the first step in primary prevention. If we are not able to achieve the goal, only then we start statins. Not on the first visit we should start a statin unless the LDL values are very, very high. So if the goal is not achieved, start statin. But once we start statin, they are to be taken for life. So this message should be told to the patient on the OPD visit. So that is my important. I think a lot of times what physician says that, okay, cholesterol will become better, we'll stop your statin or decrease the statin. So that hope should not be given to the patient.
Thank you. Do you have any question from the audience? We can take only one question as we are running the short of time. Yeah, please.
Is that an issue?
LDL level went to 5.
5.
So what was the starting level and what was the dose given to the patient?
So starting level was around 250 and atorvastatin 20 was started on the patient.
So if your LDL starting, LDL was 250 and went to 5 or 20 mg of atorvastatin. So that is not logical. You see, atorvastatin 20 will lead to something like a 33 to 40% reduction in LDL levels. Either of the two values were wrong. So I think you should, either the first value which was 250 LDL was wrong or the second which is showing 5 mg was wrong. You always cross-check when you are having such discordant values with the other lab.
Okay, sir. Thank you, sir. We can close the session. Thank you.
Thank you for a wonderful session. I would now request the chairpersons and the speaker to proceed to the felicitation area for receiving the memento by Dr. N.K. Govil. Dr. N.K. Govil to please come and felicitate our chairpersons and speaker.
Good afternoon, everyone. On this bright, academically enriching day, it is with great pleasure that I welcome you all to the second edition of LeadCon 2023. Moving forward with the inauguration, I now request Dr. Ajay Kumar Gupta, our organizing chairman of LeadCon 2023, to kindly take the stage. I would also like Dr. Nishesh Jain, our organizing secretary, and Dr. Amitesh Agarwal, our chairman scientific committee, to please join him. I would request Dr. Gaurav Agarwal to kindly come to the stage. Being a physician himself, he has successfully led to the immense growth of Max Super Speciality Hospital, Vaishali. He is currently the Senior VP Operations at Max Vaishali and the Director at Pushpanjali Medical Center. I would request Dr. Charu to kindly present a bouquet to him. I request Dr. Nishesh to extend a warm welcome and escort our chief guest, Dr. Sandeep Buddhiraja, to the stage. I request Dr. Nishant and Dr. Nishesh to kindly present a bouquet to our chief guest, Dr. Sandeep Buddhiraja. Sir has been conferred the S. Radhakrishnan Memorial National Teachers Award in 2021. He is a MRCP faculty and examiner. He is currently the Senior Director of Department of Internal Medicine and Group Medical Director, PanMax. Welcome, sir. The lighting of lamps is a symbol of hope, knowledge, and positivity. As we gather here today, let us embrace this light and hope it can guide us to a better tomorrow. Without further ado, I now request our chief guest, Dr. Sandeep Buddhiraja, and all our dignitaries on stage to kindly proceed with the lamp lighting ceremony. I also request the Department of Internal Medicine and Dr. S.V. Madhu and Dr. Saurabh Srivastav to kindly join us on stage. Dr. Rajiv, please, if you could also join us on stage.
Ah
I would now request our organizing chairman for LeadCon 2023, Dr. Ajay Gupta sir, to kindly come and welcome our august audience here.
A very good morning to all of you. And at the outset, I thank all my esteemed colleagues and esteemed guests for honoring us for this LeadCon 2023. And on behalf of the organizing committee, it's a great pleasure to welcome you all for the LeadCon. And from our rich experience for the last year, this year also we had kept this advances and evidences in diabetes. And hope we are honored to have you all to join this endeavor, and we hope that we'll find this conference very informative. I thank you all for your active participation, and I wish you all a productive and fulfilling experience. Once again, welcome all. Thank you very much, sir.
Requesting Dr. Amitesh Agarwal, a chairman of the scientific committee, to please say a few words.
So I welcome everybody today. It is my pleasure to welcome you to the second edition of the Learning Evidences and Advances in Diabetes, jointly organized by the Department of Medicine of Max Vaishali and Lotus Diabetes Foundation. As a scientific chair, my endeavor was to provide a balanced mix of both didactic lectures and interactive panel discussions. The program is designed in a way that it shall provide a platform to the curious clinicians to interact with the faculty and enrich their knowledge and skills. We are fortunate to have the best of the teachers, mentors, and experienced clinicians with us to guide, inform, and answer to our queries. With that, I welcome you once again to the Scientific Feast and hope this update marks its utility in your daily treatment care. Thank you.
Dr. Gaurav Agarwal sir, I would please request you to say a few words to our esteemed colleagues and guests.
Thank you so much. Good morning, everyone. Respected Dr. Sandeep Buddhiraja and our colleagues from Max Hospital Vaishali and the organizing committee of LeadCon 2023. It's been a pleasure. At the heart of our hospital, Max Hospital Vaishali, it's been one of the fastest growing hospitals in the last 4 to 5 years in the region where we are operating, covering every subspecialty to super specialty. But I am myself a physician by education and qualification, and as a management person or physician by heart also. So I understand the role of internal medicine in the overall dynamics of running a super specialty hospital. And the foundation of this hospital was laid on a very strong base of Department of Internal Medicine, and the entire academics and research which was initiated in our hospital was led by internal medicine, and it is still being led by internal medicine. So happy to see that we are still, focusing and on a topic like diabetes. We have all studied diabetes. In fact, the new terminology is COVID was the pandemic, but nobody is actually talking about the pandemic of diabetes, which is happening from the last 2 to 3 decades. And it is important that for managing this pandemic, the role of physicians has to be reinvented. If we could manage and control COVID pandemic, I think the next 5 years, it is important that physicians take the lead and manage it right from the primary care to the secondary care to the tertiary care level. And all these complications of diabetes, we all know, lead to super specialty and the cost of treatment to the patients also at large. So it is important that, deliberations like this organized by LeadCon and our Department of Medicine will go a long way to both reinvent the role of physicians in managing and tackling diabetes, and also to control this pandemic, because it's the morbidity and mortality of this pandemic is unimaginable. So it is important that we actually focus on this. And thirdly, I think it is also important to realize that the cost burden which is increasing in terms of care to the patients. So that is, in my summary, I think I would really appreciate that we have taken a lead in this. And thank you so much for having me here. And I must compliment everyone that you could all participate in this, small but a very crisp session. And some of these sessions I have just attended. I think the level of deliberations are of very high level. And I think that's the way to go forward. Thank you so much.
I would now finally call upon our chief guest, Dr. Sandeep Buddhiraja, to kindly come forward and enlighten us on this momentous occasion. Please, sir.
Thank you to all the organizers for inviting me here. I think I'm also a physician, and 60-70% of our scientific activities or events which we have diabetes as a topic or with a primary focus on diabetes. And when I was a student during my post-graduation days, I think the percentage contribution for diabetes in terms of academic activities used to be about 30% or even less than that. And in spite of our repeatedly doing these activities, I still feel this is a very, very important event that we must conduct. And I'll take 2 minutes. I have penned down a few interesting statistics just to sort of reiterate the fact why diabetes as a topic needs to be actually spoken about repeatedly in every event. Now we are coming to subspecialty activities, CME activities. There also, if you see, diabetes remains the focus as a subject in most of these areas, even surgical areas. So just hear me out for a minute or two. Many of you would be already aware of these statistics, but I have sort of tried to pull out very interesting figures just as an eye-opener for what the next generations of doctors are going to be bearing. So we all know that diabetes is one of the largest global health emergencies of this century. Dr. Gaurav just spoke about COVID and why diabetes is not being spoken as a pandemic. It ranks amongst the 10 leading causes of mortality, together with cardiovascular diseases, respiratory diseases, and cancer. Now, according to WHO, NCDs accounted for 74% of deaths globally in 2019, of which diabetes resulted in 1.6 million deaths, thus thereby becoming the 9th leading cause of death globally. By the year 2035, nearly 592 million people are predicted to die of diabetes, and it's all reached epidemic proportions in many developing countries led by China and India. If I specifically talk about India, we know that India is now referred to as diabetes capital of the world because it contributes to 17% of the world diabetic population. In India, according to the estimates, we have about 80 million diabetics, and that number is projected to increase to 135 million by year 2045. And the overall prevalence in our population is about 8.9, let's say 9%. The problem is the number of people who are not even aware that they are diabetic or pre-diabetic, and leave aside India, even in a country like US, 1 in 5 diabetic does not know that he is diabetic, and 8 in 10 pre-diabetics do not know that they are pre-diabetics, and this is the US statistics. And one very interesting fact about which are the regions or states in our country which have the highest and the lowest prevalence of diabetes. And it so happens that states like Goa and Kerala have the highest diabetes prevalence, and states like Haryana and Rajasthan have the lowest diabetes prevalence. And one very interesting fact which emerges as to why Kerala could be having it is because of the magnesium, low magnesium levels, and there's a clear sort of association which has been found out. So I just spent a minute talking about these figures is because the future generations or even the present generation of doctors would encounter diabetes in one form or the other. So it is always a very good idea to keep refreshing our memory, and every time we attend conferences like this, some new interesting facts come out. So I think a great event, and I look forward to many such events in future. Thank you.
Thank you so much, sir. Now I would request our organizing committee to express their gratitude to our chief guest and guests of honor for taking out their precious time and gracing us with their presence. I request Dr. Ashok Grover and Dr. Amitesh Agarwal to please present a token of appreciation and gratitude to our chief guest, Dr. Sandeep Buddhiraja. Now requesting Dr. Saurabh Srivastav and Dr. Amit Sharma to kindly felicitate Dr. Gaurav Agarwal. Dr. Nishesh Jain to now kindly present the vote of thanks to the LeadCon, to all the attendees of LeadCon 2023.
Thank you. Very nostalgic moment because all of my seniors and my mentors are here. So just want to extend all my thanks to all of my seniors, Dr. Sandeep Budiraja sir, Dr. Gaurav Agrawal sir, and special thanks to all dignitaries and delegates especially for sparing their time on Sunday morning and joining us in this mega event. Thank you very much. So for further event, I would request Dr. Anshuman to start the next session.
So moving the proceedings further, I would now like to request the chairpersons for the next session to come to the stage and be seated. Dr. A.K. Shukla, Dr. Kuldeep Kumar, Dr. Piyush Jain, and Dr. Swasti. I would now invite the speaker of this session, Dr. Sandeep Budiraja, once again to the dais to deliver his talk.
So, good afternoon to all of you. So, this is going to be our second session. For this, we have got excellent speaker, Dr. Sandeep Budhiraja. He is Group Medical Director, Max Healthcare. And he has got more than 40 publications in the last Can I put the please slides? Can you put the slide, please? Topic. Yeah. So today's topic is vaccination practices in diabetes. So you can see the all the awards and certifications. He's chairman awards Max Healthcare for 2002, Delhi Medical Association 60th Diamond Jubilee State Medical Conference Diamond Academic 2017 award in 2017, DMA Vasisht Chikitsa Ratan Award, on Doctor's Day award by the Honorable Minister of Health and Family Welfare Sri J.P. Nada in 2018. The Best Innovative Teaching Award by Association of National Board of Accreditation Institution, that's ANBAI. 37th Dr. S. Radhakrishnan Memorial National Teacher Award, 2021, awarded on 6 September 2021 by Honorable Minister of State for Social Justice and Empower, Gogli Sri Ramdas Athwala. So today we are going to have this topic, vaccination in diabetes, how important it is, by Dr. Budhiraja. Thank you, sir. Over to you.
Thank you for those kind words. I'll just right away kickstart. Sorry for the delay. I'll be speaking on what is the recommendation for vaccinations for people who are suffering from diabetes. The importance of routine vaccinations for people living with diabetes has been elevated by the COVID-19 pandemic. Preventing avoidable infections not only directly prevents morbidity, but also reduces hospitalizations, which may additionally reduce the risk of infections such as COVID-19. Children and adults with diabetes should receive vaccinations according to the age-appropriate recommendations, and there are many societies across the world, and we very routinely follow the CDC guidelines and the API guidelines in India. Despite the evidence supporting the effectiveness of vaccinations among patients with diabetes, most healthcare professionals do not routinely evaluate the vaccination status of their patients. And this actually results in missed opportunities to increase the uptake of very, very important preventive vaccinations. And what at our clinics or in our hospitals, in our services, can we do at a level of our practice to increase these vaccination rates? At every visit, we must assess immunization status of, especially if a person is diabetic. Strongly recommend these vaccinations to people who are not fully vaccinated. And it is always believed that a strong recommendation coming from a doctor is the biggest motivating factor for a person who's on the edge. Administer these vaccines. If you have these in your stock, if you do not have them, refer to the patient to the right place and make sure that there is an appropriate documentation of which all vaccinations a patient has been given and when the next dose of that vaccination is due. And in fact, if you could have a system of sending a reminder to your patients, it would go a long way in increasing the uptake of or improving the full coverage of vaccination. Now, these are complicated slides or very, very busy slides, but I think most of you have gone through this. The CDC releases this adult immunization schedule every year, just like you have a diabetes update coming from AD every year in the beginning of 2020, every year. So this also came in 2023. This is a slide which shows all the recommended vaccinations for an adult. And the next slide here shows all the recommended vaccinations for people with various medical comorbidities. And today, the focus of talk will be what are the recommended vaccinations for a diabetic. And the AACE recommends these are the following vaccinations which every diabetic should be encouraged to take. Of course, most of the age-appropriate vaccinations for diabetic or non-diabetic, COVID-19 vaccination, flu shots, hepatitis B, pneumococcal, shingles, and Tdap. Now, these are the vaccinations, and it's said that in your clinic, you must follow these principles of assessing, recommending, administering, or referring, and documentation, what I just spoke. This will go a long way in increasing the uptake of vaccinations. Now, recommendations for vaccinations assume great significance due to increased prevalence of drug-resistant influenza and pneumococcal disease and related complications in elderly. The increased susceptibility of diabetes subjects to pneumonia is mainly due to hyperglycemia, poor long-term diabetes control, longer duration of diabetes, decreased immunity, impaired lung function, pulmonary microangiopathy, and increased risk of aspiration and coexisting morbidities. Longer duration of diabetes and poor glycemic control causes 25 to 75% increased risk in pneumonia-related hospitalizations in diabetic patients, emphasizing the need for vaccinations regarding these two conditions. Now, specifically coming to the vaccinations which I just spoke about, influenza. All of us know that influenza is a common preventable infectious disease with high mortality and morbidity, especially in vulnerable population. Influenza vaccination in people with diabetes has been found to reduce the risk of influenza and diabetes-related hospitalizations and complications. In patients with diabetes and cardiovascular disease, influenza vaccine has been associated with a lower risk of all-cause mortality, cardiovascular mortality, and cardiovascular events.
Given the benefits of annual influenza vaccine, it is recommended for all individuals above 6 months of age who do not have a contraindication. Influenza vaccination is critically important, especially we know that in SARS-CoV period, a lot of co-associations of influenza virus with the SARS-CoV-2. We do not recommend the live attenuated vaccine for diabetics. So it is basically a quadrivalent high-dose inactivated influenza vaccine, an annual dose which is recommended. And you need to see the vaccine which are you giving. It has to be the latest for that year. Now, and geographical variations are also there. So for North India and Delhi region, we know that influenza has two spikes. One is the post-monsoon and other is the peak winters. So that's the reason why recommendation for our region is to give the influenza shot somewhere around September, October, so that we can cover these two shots and make sure that you are giving the brand which is of the present strain which is circulating. And these are examples of various quadrivalent vaccinations which we have, and these are all 2023 which are available. Mortality due to influenza, these are US statistics, so not very relevant, but what I want to say is mortality can range from 5 to 15% with flu in patients with diabetics, so let's not take it very lightly. And also it increases the risk of cardiovascular mortality by 2 to 4-fold. So I think it's a huge preventive benefit by giving this vaccination. So these are the indications for influenza vaccination. We have already discussed this since it's related to diabetes. So let's consider diabetes as a very relevant indication for influenza vaccination. Coming to pneumococcal, according to WHO, the mortality rate due to pneumococcal infection rates ranges from 10 to 20%, which may exceed 50% in high-risk individuals. It is estimated that people with diabetes are almost threefold at a higher risk of deaths due to pneumonia-related complications. Patients with type 1 and type 2 diabetes have a four-fold higher risk of pneumonia-related hospitalizations, and type 2 it is about 1.2-fold. And especially if it is uncontrolled diabetes. It's of interest that even with well-controlled diabetes, there's a 22% increase risk as compared to in a non-diabetic individuals. And there's various reasons. Basically, it's a T-cell immunity and the CD4, CD8 lymphocyte ratios which get disturbed, which lead an impaired leukocyte function, which are all contributing factors for increased mortality and hospitalizations in diabetic patients. Now, there are generally two types of pneumococcal vaccines. One is the pneumococcal polysaccharide vaccine, and the other is the pneumococcal conjugate vaccine. Now, the differences between the two are important to understand. The pneumococcal vaccine has been there in use for many, many years, and so one has a very long experience of it. It's a relatively inexpensive vaccine, and it gives a high serotype coverage for the invasive pneumococcal disease in elderly. So 60 to 70% coverage is there. Even in immunocompetent elderly, it is about 50 to 70% efficacy when it comes to invasive pneumococcal disease. The problems associated with the pneumococcal polysaccharide vaccine are that it is T-cell independent immune. So, you know, only the IgM antibody is produced. Response declines over next 5 years period. There is a decrease in memory B cells after PPSV23. So, you know, repeated vaccinations actually is counterintuitive. So you can't be giving a pneumococcal vaccine, as routinely said, that every 5 years. Over a period of decades, then the efficacy actually starts going down. It has no effect on the nasopharyngeal carriage, so it does not reduce the infection risk. Whereas in the polysaccharide pneumococcal the conjugate vaccine, it is a T-cell dependent immune response which gets generated. It is a much more efficacious vaccine, and it has a much stronger efficacy against the pneumococcal pneumonia. And also has a protection against the nasopharyngeal carriage. So it can potentially reduce the risk of transmission also. The experience is shorter, so it was introduced sometime in 2011. It is much more expensive vaccination. So how do we choose as to which of the two vaccination and what do the guidelines say? Now just to, because it's a very evolving topic, so one needs to understand what are the various options we have available in our country. So presently, when it comes to the conjugate vaccine, we have this PCV 13, which is, the Prevnar 13. And the pneumococcal polysaccharide vaccine is the Pneumovax 23 or the Pneumovac. Now the other two which I have shown here, Pneumosil is actually a PCV 10. It's a 10-valent vaccine. And the other is again a pneumococcal conjugate vaccine by name of Synflorix. So these are the four important brands. And if you see the pediatric guidelines in our country, Pneumosil is actually what is mentioned there, which is the PCV 10. Now, what are the recommendations? So one should use both PCV, that's a conjugate vaccine, and the polysaccharide vaccine. And the ideal thing is to first give the conjugate vaccine, that's the PCV 13, followed by the polysaccharide vaccine. And the minimum interval, if you are giving in this order, PCV followed by PPSV, is 8 weeks. But if a person has already been given a polysaccharide vaccine, that's a Pneumovax, then patient should receive the conjugate vaccine, but the interval has to be 1 year. So it's very, very important for you to take the history from the patient of a previous pneumococcal vaccine. And if patient says that, yes, I have received one Pneumovax 23, and it's been more than 1 year, you should give him the conjugate vaccine, that's Prevnar 13. If the history is not clear, then you should treat him as if he has not received the vaccine and start off by giving PCV 13, and then 8 weeks later, at least 8 weeks later, can be after a year also, you give the pneumococcal polysaccharide vaccine. And should you repeat the polysaccharide vaccine thereafter? Well, the guidelines from API say, yes, we should give one more booster after a period of 5 years from the last dose of polysaccharide vaccine. So what they recommend is one Prevnar 13, then anytime after 8 weeks, give the polysaccharide vaccine, and then repeat another dose of polysaccharide vaccine after 5 years if patient is at a higher risk. This is just what I've mentioned. These are the API guidelines for vaccination, pneumococcal vaccination in adults. CDC says something differently. And these are the latest 23 guidelines. Now in US, in West, they also have PCV 15 and PCV 20. In India, we have PCV 13. So they are saying PCV 13 should be used only for pediatric immunization. And by the way, pediatric immunization schedule is very clear. They have to be given 4 shots of pneumococcal vaccine before they achieve 15 months of age. So 6 weeks, 10 weeks, and 14 weeks. And the fourth booster before 15 months, between 12 to 15 months. With a polysaccharide conjugate vaccine, in India, we can use PCV 10 or PCV 13. In US, they say PCV 13. If a child has missed this pediatric immunization schedule of 4 doses, between 2 to 5 years of age, also you can make sure that they receive 4 doses. But after 18 years of age, CDC recommends using only PCV 15 or PCV 20, not PCV 13. And they say that if an individual has been given PCV 15, it should be followed by a polysaccharide vaccine, at least 1 booster dose. But if a person has been given PCV 20, then you need not be given a polysaccharide vaccine. These are the latest CDC guidelines, which we do not follow as of now in our country. So we follow the API guidelines. Hepatitis B, the guidelines in terms of vaccination doses is same, 3 doses. But one needs to remember that as compared to general population, people with type 1 or type 2 diabetes are at a higher risk of hepatitis B, at least 2.1 times increased risk. And the reasons for this could be assisted monitoring of blood sugar and other procedures involving multi-patient use of finger pricks devices, which are actually not to be done. So under 60 years, hepatitis B vaccine in diabetics is must if he has not taken. Above 60 years, unvaccinated, whether to give hepatitis B or not is left at a decision or discretion of a treating physician. Now, COVID-19 and diabetes. Now, this was a publication from our hospitals. I'll read out the conclusion. The group with diabetes had higher proportion of severe cases, so 20% versus 9% hospitalization, mortality 6% versus 1% diabetics versus non-diabetics, ICU admission 24% versus 12%, and oxygen requirement 53% versus 28%. So diabetics clearly had a very bad time during COVID, especially when it was a Delta wave and people were unvaccinated. Post that, vaccination and change of strains to Omicron has completely changed the demographics of COVID. We know that, and it is no longer remained as deadly a disease as it was. Vaccination has now really saved lives. These are all different types of COVID vaccinations. Won't go into details of that. These are the, there was a big discussion about the booster dose. People who have taken 2+1 dosing should they take a fourth booster? And this was a discussion because there was a small spike just few weeks back. WHO has clearly said, people who come into high-risk group, and diabetics will be part of this group. This is CDC guidelines, mind you. These are again not presently applicable for India. CDC says high-risk individuals, after they have completed 2+1, should get a fourth dose or a second booster at least 6 months after the first booster. People with low risk need not. People with medium risk, the risk has to be individualized. The Indian guidelines still say 2+1, irrespective of your risk, because only 27% of Indian population had gotten the third dose. So the focus for our country is to complete the third dose or the first precautionary dose. These are all different types of vaccinations which were available in our country, which are available in our country. But presently, if you ask me, only Corbevax and Covovax is what is available if you open the CoWIN app. And the other is that nasal vaccine, the Incovac. All these are now available for use in different sets of people, starting from 12 years of age. Coming to shingles, we know that it's a chickenpox virus which one would have had earlier in life, remains in the dorsal root ganglion, and later can reactivate depending upon the body's immune status or the age. And this graph is trying to show you how the chickenpox or the zoster immunity wanes off after 50 years of age, and hence there is a clear need for people above 50 years of age, especially the vulnerable and at-risk population, to be given a shingles vaccination. And this is just to see the risk of getting or reactivating of chickenpox virus. If you are a diabetic, the relative risk is 1.68. So it is significantly increased as compared to a non-diabetic. Hence, it does make sense. And now, just about a week back, officially in India, Shingrix vaccine is now available with a schedule of 2 doses. The second dose is to be taken 6 to 12 months from the first dose. And studies, short-term, medium-term, long-term, have confirmed the safety and efficacy of the vaccine against prevention of zoster infection in individuals. And here also, if you see the fourth line from top, diabetic, 91.2% efficacy in terms of preventing the zoster. And these are long-term 10-year study where the immunity status of patient after 2 doses of Shingrix vaccination has been maintained very well. Coming to an equally very, I would say, controversial area about human papilloma virus, the HPV vaccine. We know that it is effective, but we hardly use it. And the reason is probably we are skeptical about the efficacy. We don't know whether we should give it to our patients or not. But one needs to understand that HPV is a very common sexually transmitted infection. And HPV acquisition generally occurs soon after the first sexual activity. Most HPV infections are transient and asymptomatic. Persistent infections with high risk of HPV types can lead to development of cervical, anal, penile, vaginal, vulval, and oropharyngeal cancers after several decades of infections. Most new HPV infections occur in adolescents and young age, and although most sexually active adults have been exposed to HPV, new infections can occur with a new sex partner. 3 prophylactic human HPV vaccines are available, and I'll just show you the diagrams, it will be easy. So we are aware of Gardasil. So there's Gardasil, which is 4-valent. There's Gardasil 9, which is 9-valent. Then there's this Cervarix. I'll just take one more minute. The Cervarix, which is the 2-valent vaccine, which is the older form of HPV vaccine, which has been stopped being used. And you might have heard of our first indigenous HPV vaccine, which was launched by Serum Institute under a lot of fanfare in January this year. And there's a huge cost differential. This Cervavac, I'm told, would cost somewhere between 200 to 400 rupees, whereas the Gardasil 9 runs in quite several thousands. So who is to take? Between 9 to 26 years And if you have, the best time to give is about 11 to 12 years, but if you have missed, the catch-up vaccination can be done at any time. What about adults above 26 years? Yes, between 26 and 45 years also, you will give the HPV vaccines, and both males and females are eligible candidates. It is given either as a 2 or a 3 dose schedule. If you are starting between 9 to 14 years of age, it's a 2 dose schedule, 0 months and 6 months. And if you start the vaccination after 15 years of age till 45 years of age, you give 3 doses, 0 month, 1 month and 6 months. And there is no pap smear screening or no other specific precaution or prevention to be taken. Tdap, now we used to historically give TT boosters, so that has to be done away with. So if a person has not received Tdap ever in his life, or there is no history available, please give your patient 1 Tdap and then follow it up with every 10 years booster. And the booster option is left up to you. You can give a booster of either a Tdap or a TD. TT is not to be used any longer. So 1 dose of Tdap, and 10 years later, every 10 years, either a booster of Tdap or TD, whichever you want to use. So I won't go into details, and this has to be given during pregnancy also. The best time to be given in pregnancy is 27 to 36 weeks, although it can actually be given during any period of pregnancy. And for a post-exposure, or a person has had a wound and you want to give a tetanus shot, if a person does not have a history of having taken a tetanus shot earlier or has taken but is not aware, even at that time, please give the patient TD rather than TT. So I think I'm through, and this is the last slide. Vaccinations, contraindications we are all aware of. Allergy to any previous vaccination, risk of GBS or a history of GBS in past. Egg allergy is spoken a lot. A person who has egg allergy should not take flu vaccine, but actually it is more important not to just take the history, but what type of allergy it was. So if a person has had a severe allergic reaction to egg in form of anaphylaxis, then it's a contraindication. Mild allergies after eating egg is really not a contraindication for influenza vaccination, and every attempt should be made by each one of us as professionals to vaccinate ourselves, our families, and our patients, at least with these few vaccinations, most important being the flu shot. Thank you.
Thank you, Dr. Budhiraja, for excellent deliberation. Sir, I have got only one question to ask you. What happens to our innate immunity? Because we are giving so much of vaccination. So have we any study to say that what has happened to innate immunity?
I think that's a very interesting question. So vaccination has been one topic where there are a lot of, it's a topic for a debate where equal number of people will be for and against. Yes, if the reason for following these guidelines and the change of vaccinations over the period of year is for 3 reasons. One is to develop a good immune response to as many serotypes of that strain of infection. Number 2, to maintain that levels of the immunity you develop for as long as is possible, and to boost it for when it starts going down. But clearly it is known that over-vaccination is harmful. Over-vaccination can be counterintuitive, and I showcase in case of pneumococcal vaccination, where one sometimes sees this happening that every 5 years you take it. It is actually counterintuitive because after few shots, the protection offered by additional doses may actually start reducing or affecting your immunity. And the other question about immunity is why we say vaccinations only above 6 months of age is because till 6 months a child gets the vaccine, all the protective antibodies from mother. But after that, most of the antibodies go down to a level where they do not remain protective any longer. And when we talk about primary prevention in cardiovascular disease and in diabetes and now in cancer, I think these vaccines have a huge role to play in terms of primary prevention for infectious diseases, and now we know for certain in many cancers. And overall, they go a long way in reducing the morbidity and mortality. Today we are talking of diabetes, so in this context. So I would definitely say yes, innate immunity is what we are born with, but it needs to be supplemented by additional infections, and many times these infections were not even COVID, for example. Nobody could ever have had an innate immunity against COVID. So vaccinations do have a very sound place when it comes to wellness and primary prevention. Yes.
booster for hepatitis B and rabies?
So hepatitis B, the only reason for giving a booster would be if a person is a non-responder. How we know that a person is, so first thing is ask a question whether you have taken the full 3 doses of vaccination for hepatitis B. In a low risk individual, I would not bother much beyond that. I would not routinely go and start testing his antibodies level. In high risk individuals, in healthcare professionals, and anybody who's working in the hospitals, nurses, we must get our antibody checked. If the antibody levels are below 10, definitely you are a non-responder, you take an additional booster dose. So if a person has severely immunosuppressed condition, CKD, then we give a higher dose of hepatitis B rather than 20 micrograms, we use of 40 micrograms. We also have an option of instead of using 3 primary doses, using 4 primary doses. In terms of rabies, very, very controversial subject. I would not really want to answer that whether everybody should take a booster or not. Again, I think it would depend from geography to geography. Rabies, India still has a very high load, especially in certain areas. It would make sense, again, in context to diabetes, there is no difference whether a diabetic should be offered a rabies vaccination or a non-diabetic. That recommendation, and that's the reason I missed talking about these vaccinations like meningococcal vaccination, rabies vaccination, hepatitis A vaccination, and chickenpox, because the guidelines for these do not change whether you are a diabetic or a non-diabetic. So you have to assess the risk-benefit ratio of taking rabies vaccination.
Hello. Hello, I am Dr. K.K. Jain. I want to ask.
I think we, sir, can we take the questions at the next session?
You have been talking about, this is herpes. Is it relevance, and should a general person should be advised Shingrix, and what dosage?
So actually the guidelines for Shingrix is that everybody should take it after 50 years of age, irrespective of asking chickenpox history, because it's known that a lot of people who will deny having had chickenpox actually have had chickenpox as a mild asymptomatic disease. So practically the recommendations, the guidelines are everybody takes it above 50 years of age. It's 2 doses, 0 and 6 months. The 6 months can be taken anytime between 6 to 12 months, and that completes the vaccination schedule and gives you a long-term protection. So that's the guidelines. Especially if you are immunosuppressed or you have diabetic, then the recommendations are even stronger.
Thank you, sir.
Thank you.
Thank you for your excellent talk. So we just close this session now.
Hello, 1 second. But if the age of the person is 70 years, then still you recommend 2 doses of herpes zoster vaccine?
Ji sir, recommendations are above 50 years, the doses are 2 only.
2 only.
Yeah.
Okay, thank you.
Thank you, sir.
Thank you, sir, for a wonderful and informative session. I would request Dr. S.V. Madhu, sir, to felicitate our speaker, Dr. Sandeep Buddhiraja. And sir, I would request you to also felicitate the chairpersons. Our next session is a panel discussion, and for chairing the session, I would request the chairpersons to come to the stage. I would invite Dr. Jimmy Pathak, Consultant Endocrinologist at Max Hospital, Dr. Pooja Garg, Consultant Medicine at Metro Hospital, and Dr. Ashok Kumar, Professor and Head, Department of Medicine, Santosh Medical College, Ghaziabad. I would request the esteemed panelist for the session, Dr. Anupam Prakash, Director Professor of Medicine, Lady Hardinge Medical College, Dr. Saurabh Srivastava, Professor of Medicine, JIMS, Greater Noida, Dr. S.V. Madhu, Director Professor, Department of Endocrinology and Metabolism, UCMS and GTB Hospital, And the session will be moderated by Dr. Shubha Lakshmi Margarikar, Professor of Medicine at Lady Hardinge Medical College. I invite you, ma'am, to please come to the stage and take it.
Thank you, Dr. Anshuman. And thank you, organizer, for this wonderful session of type 1 diabetes mellitus, a road ahead. So we have heard many things, many aspects about type 2 diabetes, which is very important. But type 1 diabetes is also important as the incidence of type 1 diabetes is also increasing over the years. So for this panel, we have, for this panel discussion, we have panel of experts, Dr. Anupam Prakash, Dr. Saurabh Srivastav, and Dr. S.V. Madhu sir. So moving on to this session, we have the question, what challenges do we face while treating type 1 diabetes mellitus in adult patients? We see these patients in pediatrics, but in adults, what type of challenges do we face? So Dr. Anupam sir, I would like to know from you about this.
Well, thank you, Dr. Shubha Lakshmi. Thank you, organizers, for giving me an opportunity to be here. Type 1 diabetes is a challenge for everybody, not for the general practitioners, because we don't find so many type 1 diabetes, as Dr. Shubha Lakshmi already said. But yes, we at centers like ours, at Dr. Madhu's place, we do have type 1 diabetes, who are whole lot of them, as in adults who are being followed up. So even one patient in general practice needs attention, and challenges could range from a lot of issues, like number one, in adulthood, finances is number one. So you require for monitoring, you require for even the insulin which is to be purchased, because most of the type 1 diabetics are not from upper or a good socioeconomic strata. They are usually with the lower middle or lower socioeconomic strata. So there is a continuous monthly drain, financial drain on the patients. Number two, obviously, even in younghood as well as in adults, the pain of finger pricks, monitoring, as well as the pain of injections. That is number two challenge, which is always there for type 1 diabetes, vis-a-vis type 2 diabetics. Number three would be psychological issues. So patients, especially when they move from adolescent to adulthood, they understand the nitty-gritties of the thing, living with a chronic disease and with their peers, with their college life, with their job, when they go into jobs also. So those are the issues which are actually very prominent. Apart from that, there are psychiatric issues also, like anxiety and depression, which is very, very common in these patients. So there is a whole lot of challenge that is for the physician dealing with these patients as well as the patient per se.
So thank you, sir. It is very correct that financial, psychological, these are the few issues which are very important. So in the same this thing, moving on to the next question. So are these challenges different than in type 2 diabetes mellitus, and why? So Dr. Saurabh sir, I would like to know this from you.
As Dr. Anupam has already defined the challenges in type 1 diabetes as compared to type 2 diabetes, and these challenges are definitely different in type 1 diabetes as compared to type 2 diabetes. Type 1 diabetes usually is diagnosed in the early childhood and adulthood. So, as already said, that there are psychiatric problems, there are psychological issues, there are peer pressures. So these are the pressures which are different in, not in type 2 diabetes, they are in type 1 diabetes. They are peer pressure. The patient has to take insulin while going to school. He has to eat regularly. He is somewhat, what schools differentiate that he is diabetic, so he should not take part in plays and all that. So there's a depression type of thing, there's a psychiatric issues develop in the child. The other thing is that when this type 1 diabetic patient goes to adulthood, then there is a sort of insulin resistance which develops, patient becomes obese, the lifestyle is not the same lifestyle as it was earlier. The sedentary lifestyle takes up, so patient becomes insulin resistant also. Then again, you have to balance how what and how to be treated. So these challenges are definitely very different from type 1 diabetes, not as that of type 2 diabetes.
So thank you, sir. So very correctly said, type 1 and type 2 diabetes disease is same, but challenges are somewhat different because they have to deal with different aspect of life. As type 1 are the children and adolescent, and type 2 are adult grown-ups facing different challenges along with the disease itself. So moving on to the next question or next aspect, that how does we monitor a patient of type 1 diabetes, and do we have any newer option for that? So for this, I would invite Dr. Madhu sir to please throw some light on it.
Thank you, organizers, for inviting me on this panel. I think the need for monitoring, there are two aspects of monitoring. One is the monitoring for complications and the disease per se, and the glycemic monitoring. Both are important, and I think it's to some extent linked to the various challenges that have been expressed. And what we need to understand before we answer this question is that challenges of complications are far more in a type 1 diabetic who is an adult, because he's already had a long period of diabetes during his lifetime, whether it is type 1 or a type 2, number one. Number two, the nature of complications also are different, not only the acute metabolic and as well as the long term. Both are more. So therefore, you need to monitor closely for the occurrence of these complications. That's number one. And therefore, in order to prevent these complications, you have to be more, or you have to do a stricter monitoring of their glycemia also. Because if you don't do that, we all know that these complications are going to be more. Therefore, as opposed to a stable type 2 diabetic, the question of glycemic monitoring, I think, becomes critical in a type 1 patient. And an adult type 1 patient, because he's already had a significant duration of diabetes, that much extra risk of complications, that much more important monitoring. The most important way of monitoring, obviously is known to all of us, is the self-monitoring of blood glucose. And most type 1s and almost all type 1s are insulin users. And these patients therefore require close SMBG at home. Many times, if in the initial phases, particularly when the sugars are not yet controlled, you may require multiple times a day. Once it is stabilized, you may, make a scatter. That's what we do in our clinics, because you can't expect them to monitor or prick themselves so many times a day. At least a scatter over the period of a week, where you have a rough idea of glycemia over the 24-hour period, which could be fasting PP on a particular day, pre-lunch, post-lunch on another day, pre-dinner and a post-dinner on a different day, and a 3 AM if required during the course of the week. So that kind of an SMBG is the usual way of glycemic monitoring in most type 1 diabetic patients in our clinic as well in the hospital. What you were asking is for any newer modality.
Yes, sir.
The newer modality is also known to most of us. In fact, it's more used these days than even the SMBG. People tend to use it much more, which we know is the CGMS, and we know the Freestyle, which is available, Libra, which is available, which can give you a continuous glucose monitoring values for over a 24-hour period, for a period of 2 weeks with one sensor, and then you can go on replacing it. I am a little, I belong to an older school of thought, and I'm a little conservative on this. While it has its advantages, while people are moving and shifting, and I must say that, the guidelines are also shifting towards CGMS-based targets, no denial, and it's definitely a far more efficient way of monitoring. But at the same time, I don't think it's a replacement for SMBG. It is a supplement. In appropriate cases, selected cases, it can be very useful. But I will not, at the moment, recommend it as a routine way of glycemic monitoring for any type 1 patient, be it a child or an adult.
Okay, sir. So according to this, the glycemic monitoring as well as monitoring for complications are very important. SMBG is the mainstay for monitoring, and CGM in special situations will be helpful. So moving on to the next question on the same continuation, how CGM or Dexcom helpful in management of type 1 diabetes? And Dr. Anupam sir will be throwing light on this thing.
Well, Dr. Madhu has already clarified a lot on it, and Dr. Shubhlakshmi also partly while asking the question has clarified on the same. Continuous glucose monitoring systems are definitely a boon, but yes, they should be used selectively. Number one, the cost constraint is always there, and it adds on to the burden of the pills and SMBG to the patient. And as Dr. Madhu rightly said, we should understand that it is a supplement to SMBG. Yes, you can use it in patients who are difficult to control, maybe those brittle type 1 patients. You can use it in patients who have achieved a fair degree of control and now you want to fine tune their control. Maybe those patients who have HbA1c of around 7, 6.5 and you want to achieve it to be less than 7.5. You can use it as a motivational tool, because once the patient has that 24 hours, you can ask the patient to see what food items or what exercise actually benefits the patient and what actually increases the patient's blood sugar levels. So overindulgence in some food items or overindulgence or timing of meals, so those things can be fine-tuned, and especially for a type 1, yes, it is good if the patient can afford, and as a supplement to SMBG, it will be beneficial because it will reduce the number of pricks, but yes, at a cost.
Can I just add?
Yes, yes, sir.
What I need to add is actually we should, when we advise SMBG, I think the treating physician should be clear on the goal, on his goal. What do we expect to achieve by giving him SMBG? Unlike, prescribing it as a routine manner in everybody. Because why I'm saying this is I've seen a couple of patients very recently in our clinic who were referred, who had already been type 1 diabetic patients, who were already on CGMS. And when I asked them that since when you're on the CGMS, they've been there already, I think, for the last 3 months. And I said, till when do you propose to continue this and what you have been advised? They said, we don't know, probably lifelong. No, this is the extent to which you can misuse CGMS. Please don't advise it as a lifelong monitoring tool. That is definitely a no-no. And I would think that when you're advising a CGMS, unless you're wanting to change something based on your CGMS values, I don't see any extra advantage on doing a CGMS. If you want to alter your treatment based on what you find in your CGMS, then surely you should go ahead with it. Maybe 1 cycle, 2 cycles, that's up to you in a given patient to know the trends. And then once you've known the trends, then you know what to do. After that, CGM is of no use. Thank you.
Yes, sir, very rightly said. So CGM or any other newer tools, these should be only used in a selected situation wherever indicated. Moving on to the next question. What are the available treatment modalities, including newer ones, for this type 1 diabetes mellitus? Dr. Saurabh, sir, would you like to answer this?
Type 1 diabetes is a disease where the patient is insulin deficient. So the modality of treatment remains insulin for type 1. So there are n number of insulin which are there, but I must say that type 1 diabetic is a patient which is not controlled on premix insulin. So don't try to give premix insulin to these patients. They require a basal bolus therapy, and which is apt for these patients. There are newer insulins which are there. There is fast acting aspart is recently been introduced. Along with that, we have a longer acting insulin in the form of glargine, in the form of degludec. All these things are there. We have fast acting aspart. We have glulucin. We have Lispro. So all these insulins are there. So the mainstay of the treatment remains insulin. Recently, monoclonal antibody is being approved by FDA, that is teplizumab, which is being approved for delaying the onset of type 1 diabetes. I'm not very sure whether it should be used, how it is to be used, but it is just for the delay of type 1 diabetes from stage 2 to stage 3. So it is just for the delay. It is just a matter of fact that patient is type 1 diabetic and he will require insulin in a due course of time. However, you can delay the onset of the treatment. And as the patients are going to the adulthood more as compared to the previous times, so the patient, I have already told that patient might be obese and all that. So anything which is acting, there are trials going on and there are some studies which are there in progress that any modality which is not acting on beta cells can be helpful in type 2 diabetes if there is some other mechanism acting on that. Suppose that insulin resistance is there, then probably metformin might help, SGLT2 inhibitors might help, but these are under investigational product, nothing is approved. Only approved treatment is insulin and the monoclonal antibody which I have talked about. Sir, you want to add anything?
Okay, so basal bolus regimen is the main thing which we have to advocate in type 1 diabetes, and other newer modalities, whatever has been talked about, is on trial basis, approved, but yes, we have to choose where we have to give or not to give. So, where do we place patient's education, as sir has already talked about? So, where do we place patient's education and counseling in management of type 1 diabetes mellitus? Dr. Madhu, sir.
As you've realized by now, from what the panel has been telling you, there are too many issues that a type 1 diabetic patient faces, which the type 2 diabetic patient may not be facing. Insulin use is one fundamental thing, and insulin use is not easy to implement. Even if the patient has become an adult, I hope we are talking about adult patients, because in children it's far more important. But in adults, even in adults, one needs to understand the nuances of insulin injections, and it's not easy, and therefore education is a must. So that's one. Two, when you're having multiple doses of insulin injections, as was mentioned, that we need to put them on basal bolus regimen most often, the chances of, alterations of the blood glucose, development of hypoglycemia risk, and all those things increase. Again, education is important. The patient, a type 1 diabetic, can lapse into even acute metabolic complications, as I said in the beginning. That's a challenge which a type 2 diabetics don't face that often. And therefore, you have to be closely monitoring. Don't allow, even during sickness or other situations, for the patient to suddenly lapse into an acute metabolic complication like TKA. Therefore, you require the patient to know in detail the sick day rules. I mean, even a type 2 diabetic needs to know it, but a type 1 diabetic cannot just do away with it. It's critical. Therefore, to summarize, I think education, to my mind, is the most critical aspect of managing a type 1 diabetic. Insulin, diet, all that is fine, but unless you have a proper educator, or the physician himself plays the role of the educator, and spends enough time to educate the patients not only on the aspects of insulin use, complications of insulin treatment, hypoglycemia, sick day rules, and all the other. And in addition, somebody did mention, Dr. Anupam mentioned about psychological aspects. While these are more in children and adolescents, they do persist even in adulthood. And if you don't address those issues, the sugars keep swinging up and down, CGMS or no CGMS. And therefore, education, I think, is the most important aspect of treating a diabetic patient, particularly a type 1 diabetic patient.
Yes, sir. So very correctly said. So education, awareness, and counseling is very much important in type 1 diabetes patients. We have seen the treatment, we have seen the monitoring. Moving on to some of the special issues in type 1 diabetes. So what special advice should we give to type 1 diabetes mellitus female who is pregnant or who is planning pregnancy? Dr. Anupam Prakash, sir, I would like to know it from you.
Well, since time is running out, I will be very brief. Yes. For a patient, type 1 diabetes who is planning to become pregnant, or who is already pregnant, two things are foremost in the mind of the patient per se. Number one, that what will be the outcome of pregnancy, and number two, what is the likelihood of the offspring developing diabetes. So the outcome of pregnancy, if the glycemia is well controlled, there are no ifs and buts, so it is virtually the same as a non-diabetic. The only problems would be, yes, managing hyperglycemia or managing hypoglycemia, which should not occur. So obviously a strict control is required, HbA1c less than 6.5, that has to be emphasized even at the pre-pregnant stage also. Number two, what is the prospect of the patient's offspring becoming diabetic? So we will need to allay the fears of the diabetic patient, type 1 diabetic patient, because the propensity of a child of offspring of type 1 diabetic becoming a diabetic later on in life is much less than a type 2 diabetic. So if the female pregnant patient herself is type 1 diabetic, the chances are probably 1.3 or 1.4%. Vis-a-vis if the father is type 1 diabetic, which is 6% in a study that has been proven. And compared to type 2 diabetics, if one parent is diabetic, that is about 15%, and if both parents are diabetic, later on development in the offspring is around about 60 to 75%. So that has to be explained to the patient, because if the anxiety is less, the glycemia also is better. So these are two important points, other than say at least rigorous monitoring during pregnancy is important, and an HbA1c less than 6.5. That has to be explained before getting pregnant, and two drugs need to be removed, ACE inhibitors or ARBs and statins. They will need to be, because they are potentially teratogenic. Thank you.
So these are important points to be taken care. We have just 2 questions. I will request the panelists to just throw light on this. So what advice to be given to type 1 diabetes individual when they are traveling? Dr. Saurabh, sir.
So as the time is less, the only travel advice is that the insulin should be with the patient. He should have at least 2 sets of insulin with them. If he is traveling by flight, then probably if he is on insulin pump, then probably he should have pens also while traveling. And he should have ample amount of snacks along with him, because he might land up in hypoglycemia. And the second thing is, which is important for travel, is that if we are moving from north to south, then probably there's no change in dosing of insulin or duration of insulin and duration of use of insulin. But if we are traveling either eastward or westward, then the things become important. If you are traveling towards east, you are having a shorter duration, so probably you have to give a shorter dose of, lesser dose of long-acting insulin and a missing of regular insulin. And if you are traveling westward, then probably the duration of travel becomes longer, so you will need an additional dose of regular insulin. The second thing which is important, that don't pack your insulin in your check-in luggage. So if you're traveling by flight, then your insulin should be with you in your cabin luggage. Probably these are the important advices which should be given to a patient while traveling.
So with these advice, moving on to the next question, what percentage of elderlies can have type 1 diabetes, and what all aspects are to be taken care of while treating these patients? Dr. Madhu, sir, please.
I think the question probably was framed because we are seeing lifespan improving in type 1 diabetics,
Yes,
and
yes,
people
sir,
are reaching elderly age group.
Yes,
That's
sir.
why probably you
Yes,
framed
sir.
this. I don't think I can give you figures of that kind, the way you're asking what percentage of elderly have type 1 diabetes. What I can tell you is, if you have a population of type 1 diabetics, 20% of them would be in the elderly age group. Let's put it that way.
Yes, sir.
These days, let us put it that way. Why? Because, even those who were called type 2 diabetics to a certain stage would have become type 1, or if you were to do antibodies with them, would turn out to be type 1, which you may not have done ever. So some of them are actually type 1, which are being treated as type 2. So that's one. So it's important to realize that with increasing lifespan, you will find type 1 diabetics even in the elderly. I think that's the important part. How will you manage them? What are the important? Only 2 things I will say here, because we've finished with the time. These patients have a lot of comorbid conditions. 2, taking insulin and following not medication, but self-management will be far more tougher in this age group. And therefore, you have to pay attention to these. Educators are far more important. You probably have to use less complex regimens. You have to deal with lesser targets, less stricter targets, because if you don't follow these, risk of hypoglycemia, aggravation of comorbid conditions, decrease in quality of life, and mental instability or cognitive defects will be more. Therefore, you need to be cautious about all these things. And I think these are the challenges in the elderly.
They will be probably on a basal bolus regimen. So the monitoring has to be far more vigorous for them, and that is what is a challenge for all type 1 diabetics. The other thing is, as has already been said, the chances of them having complications is much more. So again, that will require more monitoring. That was what was told by Dr. Madhu, which is very important also.
So I have a question. 5 to 15% of patients, young patients who present with diabetes, they are usually autoantibodies negative. And the usual diagnostic investigation that is available is GAD65. So if the patient turns out to be GAD65 negative, do we go for the rest of the remaining autoantibodies? Insulin empirically can always be given. But do we go for these antibodies? Do we need to add other antigen in the repertoire of whatever antibodies we are having at present, and the need for genetic testing in these patients who are autoantibody negative?
See, in clinical practice, I don't do antibodies in a single patient of type 1 diabetes. So for routine practice, neither genetic testing is important unless there are pointers towards a MODI, where you want to confirm. At the moment, it is cost ineffective to do genetic testing in everybody. Type 1 diabetes also antibodies are not required in most patients. C-peptide sometimes. Once you confirm or you don't know, you want to be sure, so maybe anti-GAD in occasional patients may be useful, but most of the time as a clinical tool, I do not think you require antibodies at all. So the question of going beyond anti-GAD doesn't, there are several problems. Unless you do the antibodies at diagnosis or in initial 3 months or 6 months of diagnosis of a type 1, the antibody levels keep going down. And if the patient has come after, let's say, 1 or 2 years, they'll be negative. So what are you gaining? And antibody negative doesn't rule out a type 1. So clinically speaking, it is not required. Only for research protocols, maybe it is.
With this,
They're chasing us from the stage and you are holding us onto the stage. As he said, depending on the requirement, we say, some of the patients of type 1 diabetes may become insulin resistant or may be insulin resistant from the beginning, partly because of the glucotoxicity, partly because they also have a type 2 phenotype, when we call them a double diabetes. So they are the worst in terms of complications and long-term prognosis. So the treatment remains the same, you still give insulin. Sometimes the dose of insulin may be high. In such situations, to control the insulin resistance, you might add drugs like metformin or other drugs. That is possible. But by and large, your mainstay remains insulin.
thank you. I thanks all the panelists, Dr. Professor S.V. Madhu sir, Director Professor Dr. Anupam, and Professor Saurabh Srivastava for being panelists in this session. I thank Dr. Sublakshmi for moderating the session. I thank the organizing team for inviting us as a chairperson. Thank you very much to all of you.
Thank you for such an enlightening session. Now for the felicitation, I would request Dr. P.C. Gera sir to please felicitate the panelists and chairpersons. For our next panel discussion, I would now request the chairpersons on the stage, Dr. L.H. Khotekar sir, Director Professor and Head of Department of Medicine and Neurology, Lady Hardinge Medical College, Dr. Gopal Sharma, Director Medical Oncology at Max Healthcare, Dr. Shelly Datta, Assistant Professor at RML Hospital, and Dr. Kuldeep Dhar, Senior Consultant Medicine. I request the chairpersons to be seated. Now I also invite the panelists for this session to please come to the stage and be seated. Dr. Sameer Kubba, Director of Cardiology at Max Healthcare. Dr. Ashok Grover, Senior Consultant Internal Medicine at Max Vaishali. Dr. Sanjeev Gulati, Senior Nephrologist and Chairman of Renal Transplant at Fortis Hospital. The session would be moderated by Dr. Naresh Tang, Senior Consultant Physician at Max Patparganj.
Good afternoon. At the outset, I thank the organizer for inviting us to chair the session. And we have an stalwarts here. India, you all know that Indians have a sweet tooth and fragile heart. So diabetes, hypertension, and cardiovascular disease go along with each other like siblings. So it's an interesting topic. Over to the panelists, please. Thank you.
Thank you, friends. So heart failure is one topic, and I always take my audience back to a class that I attended 30 years back. Professor P.L. Wahi, I still remember 1988. He took a class and he said that, look, this patient, in next 5 years, 50% of his type will not be there. So it is as bad as cancer. And of course, heart failure treatment has improved. So has the cancer treatment improved. We have had a lot of new drugs, the guideline-directed medical therapy, thanks to ARNI, thanks to SGLT2 inhibitors, usage of MRAs, usage of beta blockers. Beta blockers were contraindicated 30 years back in heart failure, but now beta blockers are one of the cornerstones of therapy, and diuretics, etc. So today we are going to discuss heart failure with some focus on ARNI, but we will not stick just to ARNI. We'll give a bird's overview of everything. So it's going to be a question which I want to ask the panelists. So Dr. Kuba, could you elaborate how heart failure was treated up until early 2000s? And what were the common problems with management in that area? And may I also say that if you could tell them about heart failure A, B, C, D, and a bit about that.
So, as you rightly said, sir, that you are much senior to me, so you belong to that era when heart failure actually had a time, beta blockers being contraindicated, now being class 1 agents in the management of heart failure. And newer drugs have now come up, especially the SGLT2 inhibitors, ARNI, very Sigwart in worsening heart failure. There's so much of role of device therapy. So before I delve into that, we must realize that we have, I believe, understood heart failure much better nowadays. And we are not just focusing on the drugs for heart failure per se, but we are also focusing a lot on associated comorbidities, which was not the case in the past. Something like iron deficiency anemia, which needs to be treated, vaccination, and so many things. ACE inhibitors and beta blockers, and then the MRAs, they formed the cornerstone of therapy in the early 2000s, and MRAs were grossly underutilized. Still, they are not that greatly utilized. The mortality was high, it still is, but as you said, sir, people are living longer. In the previous session also we were discussing people are living longer. So what happens is the treatment of heart disease per se is improving. The treatment of acute MI is improving, treatment of valvular heart disease is improving, treatment of cardiomyopathy is improving. So ultimately all these patients will land up into a common diagnosis of heart failure. And regarding the stages A, B, and C, and D, I think it's very important for us to initially pick up these patients at stage A. And stage A are those patients who are at risk of heart failure. The previous session was being discussed on diabetes. So diabetes is one of the conditions which can predispose to heart failure. So looking at the patients who are high risk, like hypertensives, diabetics, dyslipidemics. So our understanding is now becoming better, and over a period of time, I think a lot of precision medicine is coming, like has the focus in oncology, similarly in cardiology. We are now going to treat the individual metabolic signature of the patient in years to come. AI is going to have a big role. So it's a very exciting time and a very exciting era. And with newer drugs, I think mortality has significantly reduced. And especially, sir, you would agree that ARNI somehow has changed the overall thought process of heart failure. We are seeing improvement in the LV ejection fraction with this drug, which we hardly used to see in the past.
Thank you, thank you. So next question again to Dr. Kuba. How has paradigm HF changed the future of heart failure medical management?
So we all know paradigm heart failure compared enalapril with ARNI, and it was prematurely stopped. It had phenomenal benefit. More patients in the enalapril had a significant, for our practice in day-to-day is, unless you have some contraindication to ARNI, please start this drug de novo instead of starting a patient on ACE inhibitor or ARB, especially in patients who are stable congestive heart failure with LV ejection fraction of less than 35 to 40%, which we typically call as HFrEF or reduced ejection fraction.
Thank you. So actually ARNI came as a boon. And I can tell you, I have n number of patients who were doing very badly, dismally, and the moment I introduced ARNI to them, their symptomatology improved, their quality of life improved, and they would come back to me with complaints other than dyspnea, many of them. They'll say, oh, I'm feeling weak, I'm feeling fatigued. I said, how about your breathlessness? Oh, that's fine. So ARNI was really a game changer. With the advent of ARNI, how has heart failure management changed? Dr. Kuba again.
I think I mentioned that. Now I think most of the times if the patient is having a stable congestive heart failure, or even ADHF, and has been stabilized and is having a good blood pressure, I think that is the drug which needs to be started first. You can have a choice between starting a beta blocker, SGLT2 inhibitor, MRA, or ARNI. That depends upon your clinical practice and also the scenario of the patient. Suppose the patient has troublesome hyperkalemia, you might be slightly cautious in starting ARNI as the first drug. But one important point which I want to make here is the risk of hyperkalemia when you combine an ACE inhibitor or an ARB with an MRA is higher when compared to combining an ARNI with an MRA. So that is an icing on the cake, that MRA and ARNI together do not cause that severe hyperkalemia which ACE or ARB and MRA can. So that is one thing. The patient must have a good blood pressure, because ARNI at times can cause a precipitous fall in the blood pressure. Patient may not tolerate. Some of the patients may become dizzy, especially patients who are elderly, who are frail. These kind of patients are prone to hypotension. Many of the patients may be on nitrates when they don't require it. Many of the patients may be on alpha blockers, which they may not require, or maybe the dose can be adjusted. So these are the drugs which can cause hypotension. So reducing these drugs or avoiding these drugs, reducing the dose of diuretic therapy to give place to ARNI, SGLT2 inhibitors, beta blockers, and the MRAs, which are the four corners of pillars of heart failure therapy, is extremely, extremely important. It has shown improvement in the LV ejection fraction, and sir, as you said, not only the symptomatology, the quality of life, the patients start to feel better. And we have seen the LV function improving to near normal in many situations wherein device therapy has been totally avoided. So this we were not seeing, and this is our practical experience. We cannot say that this doesn't happen with ACE inhibitors or ARBs, but the number of patients which we have seen with ARNI having an improvement in the LV ejection fraction, especially because of the sacubitril valsartan component. The sacubitril component is the one which is the neprilysin inhibitor, and it acts on the BNP in such a favorable fashion that it improves not only the LV function, but also things at the molecular level in the cardiomyocyte.
So I think the message is that we should have all the four pillars getting into the therapy as soon as possible without causing side effects. So it should mean within few weeks, the patient should be on all four pillars, because heart failure is a disease which is unforgiving. The complications, the mortality, the worsening can happen very fast. So we should give them the best of all these four pillars as early as possible. And we'll see what more can we do beyond these four pillars. We'll discuss that in a while. So now I have a question for Dr. Grover. So what is the treatment approach in patients with diabetes, with heart failure, with reduced ejection fraction?
Already Dr. Kubba has told us about the management of the heart failure, and it is gaining a lot of significance because the number of patients being diagnosed and treated better, that is on the rise. Now, issue is that diabetes being a condition where you have these end organ involvement, and heart failure is one of the important manifestations which many times is missed, and the patient undergoes a damage to his cardiac function. But an important thing is that since the awareness has arisen that the diabetic patients, they have their cardiac involvement and they can develop HFrEF kind of a condition where they normally are presenting with symptoms of heart failure, where there may be dyspnea, fatigue, or edema. And if you are really observant and you are trying to, let's say, establish, maybe you can get a transient rise in the troponins. And if you have the echo done, then probably you will be able to come to a diagnosis of a reduced ejection fraction on the echo. So that's how you possibly, the clinicians or the diabetologists, they need to be careful about it so that they pick up these patients and the diagnosis is established and the due treatment is given. So first of all, the important thing would be to be aware that your diabetic patients may be having these symptoms, because all these patients have as yet not visited the cardiologist. So onus lies on the physician. And second thing is that once you suspect, you make an effort to confirm and then introduce the right treatment.
Thank you, sir. Actually, Dr. Grover has raised a very pertinent point. that these diabetic patients go to a diabetologist. So I have one question for Dr. Kuba. A patient who is, let's say, 4 years, 5 years into diabetes has reached a physician's clinic, and should that patient be doing NT-proBNP or echo for that patient in the first visit or so?
It's a very important question, and I think there's no clear-cut answer to it. HFpEF is also a big problem which we are now encountering. This is what we used to say as LV diastolic dysfunction in our training days. Now we have a terminology known as heart failure with preserved ejection fraction, and its prognosis is also as worse, maybe slightly less, but as worse as heart failure with reduced ejection fraction. And I think biomarkers have played a very important role in diagnosing these patients early. And as I said initially, sir, you were asking me about discussing the stages A, B, C, and D. So we have actually done some screening camps in our clinic, and we have found that the NT-proBNP levels in hypertensive and diabetic patients at times have been on the higher side. So, I mean, NT-proBNP is a non-specific marker. It has more of an exclusion value rather than inclusion value. So if the patient is clinically having signs and symptoms of heart failure, then probably doing an NT-proBNP can help. If the patient is not having clinical signs and symptoms of heart failure but is at risk, like stage A, again, the role of biomarkers is there. It will make you more cautious, it will make the patient more cautious, but you must know that what are the conditions in which the NT-proBNP can be high except for heart failure. So clinically, if the patient is hypertensive, diabetic, and the patient has no other features of breathlessness, you do his echo. See, echo is also a big problem. If doing a proper echo and looking at the LV diastolic parameters mostly is a job, it's a task which even good cardiologists are not able to do. So a good echocardiography with features of shortness of breath and clinical symptoms usually makes the diagnosis, but to make things easy, the addition of biomarkers at times helps. It's more of a prognostic marker in patients who have established disease, more of a diagnostic marker in patients who have at risk of disease. And I think it must be used judiciously. It's not a class 1A indication, and we are still learning how to use it to benefit to our patient. We cannot do in every patient.
Also, doing a good echo, looking for longitudinal strain is very important, which a lot of our echocardiographers don't do. If you want to pick up early dysfunction, I think that is one of the keys too. So now, sir, Dr. Grover, what is the evidence supporting sculptural valsartan as first-line therapy in heart failure with reduced ejection patients with diabetes?
I think in the last couple of years, since this drug has become available and the use has increased tremendously. And one of the important things which forms the basis of this is that the paradigm heart failure trial, where they found a significant increase in the quality of life and the survival in patients of heart failure once this medication was used. So I think that that evidence in that heart failure trial has prompted many of us to put it into clinical use, and that's how we find that the same thing is being translated into the clinical experience too.
Thank you, sir. So diabetic patients are no different. If they have reduced ejection fraction, they should be given the benefit of this beautiful drug that improves the symptomatology, quality of life, improves ejection fraction, and probably no other drug improves ejection fraction and cardiac reverse remodeling that ARNI does. I don't know of any other drug that does the same. So I think we totally agree with Dr. Grover on that. And one more. So do comorbidities like diabetes have an impact on cardiac remodeling and heart failure with reduced ejection fraction?
Yes, absolutely right, that the condition of diabetes has got a far-reaching impact than we can possibly imagine. And it does weaken the myocardium, and it also affects the vascular system, coronaries. So therefore, the diabetes plays a very, very important role in affecting the heart in more than one ways. And many of these patients, they are presenting to you as HFrEF, and they may have normal coronaries, but weakened heart. So I don't think there's any denying that one of the ways diabetes is affecting your heart is by giving this reduced ejection fraction state with other things being normal.
So that is practically diabetic cardiomyopathy. There is myocardial dysfunction. Patients can have low ejection fraction with normal coronaries, and it's a disease entity in itself. Also, ARNI, I was reading.
And we have seen that the use of these ARNIs, that improves that cardiac remodeling which we are talking about. So that observation on the paradigm heart failure study, so that is again a very encouraging thing, because at least you can do this reversal and achieve a better myocardial function.
Since we are discussing diabetes and ARNI, ARNI also does improve glycemic parameters and decreases insulin resistance also to some extent. But that is just a corollary. And now we go to Dr. Gulati. Dr. Gulati was with me in PGI Chandigarh many years back. Sir, how has RAS inhibition impacted the treatment of renal dysfunction in heart failure?
So yeah, for many years, ACE inhibitors were the frontline agents, the pillars of therapy when I started my practice. And obviously there were limitations both in terms of hypotension and hyperkalemia. Hyperkalemia becoming, was the prime bugbear, something that, we were really scared of, and because it can cause sudden cardiac death also. And then ANI came, and as also highlighted by Dr. Samir, it's made a sea change as far as treatment is concerned, of heart failure is concerned. Heart failure kidney disease are closely related. About 30 to 60% of all chronic kidney disease patients, again, a lot of them being diabetics per se, that's one reason, have some degree of heart failure. And all patients, a significant number of heart failure patients develop acute kidney injury during the hospital stay. So that's why there is, a close connection between the nephrologist as well as the cardiologist when you're managing such patients. And as I said, RAS inhibition has been central to the management of heart failure for a long time.
Okay, yesterday I was reading an article, usage of ARNI in stable dialysis patients.
Yeah.
So ARNI, we were always using eGFR more than 30. But yesterday I came across two.
Absolutely. I'll share with you, actually, we had a patient, she was visiting India, she was on peritoneal dialysis, and then she developed some infection, worsening of heart failure, and we had literally put her on daily dialysis.
Yes.
And the challenge was actually to get her to fly back to US.
Yes.
And finally, since we needed that dialysis holiday for about 24 to 48 hours, and we could see that this is all heart failure. And so we put her on ANI, and we gave her a trial of dialysis during hospital stay. And sir, there was a dramatic change. And we have been increasing over the last few years. We have been using ARNI in our dialysis patients. And the limiting factor is hyperkalemia, and that is taken care by dialysis. I had another patient who was literally bedridden, who could not walk to the washroom. And then in close consultation with our cardiology clinic, I said that let's try, this guy is in heart failure, he can't, his quality of life is miserable. And a week later he tells me that, something has changed. I don't know whether it's the pill or did you change my dialysis. And this was a patient who could now go to the washroom, his quality of life improved dramatically. So the answer is yes, it's been a journey of learning for us. And as far as dialysis patients are concerned, we are much more aggressive in using this therapy because we are not limited by hyperkalemia.
And in case hyperkalemia does come, do you use anti-hyperkalemia drugs?
Yeah, so anti-hyperkalemic drugs, again, if it's a dialysis patient, you can, titrate the potassium levels very safely. It's very easy. As far as anti-hyperkalemic, we are limited because the only anti-hyperkalemic drug that we have is the sodium-potassium polystyrene, which is a very poor anti-hyperkalemic drug. It acts in the distal colon. So it's more for, just for the patient's perspective, efficacy is very poor. The ideal drug is petiomar, which is still, because of cost issues, licensing issues, is not available in our country. So hyperkalemia remains a major challenge, and whenever we see these patients, we look at other factors. A lot of these patients, in especially Indian diet, if you see, it's very rich in potassium. So we look at all the other factors. A lot of them are taking the alternative therapies, Kymchuran and whatnot. So if you are able to get all the things out, then hyperkalemia becomes relatively easier to manage.
And what is the optimum way to use ARNI in worsening renal function?
Okay, yeah, that's a very practical question because as again was discussed earlier on, hyperkalemia is a major risk factor. So we start with smaller doses. Some of my cardiology friends call it homeopathic doses, but that's the way it's a learning. So we start off somewhere with 25 milligram twice daily and then titrate it upwards. And in fact, very few of my patients are on 100 milligram twice daily, very few. Hardly 50 twice daily is more or less a ceiling figure.
And how do you monitor the potassium levels?
Okay, so we warn the, counseling is very important once you start these patients who have chronic kidney disease. And you tell them that you have to be very careful with all your potassium levels. So the first serum potassium, we ideally do about 5 to 7 days post starting of therapy. And thereafter, say every 2 to 3 weeks, and we tend to back off. But each and every visit, I think it's mandatory to monitor the serum potassium levels and counsel these patients again and again. A lot of these patients we ended up learning, they are on salt substitutes. That's another common contributor to hyperkalemia. So tell them that, look, now it's the time you switch back to your regular salt, take it in moderation, but stay away because salt, all these salt substitutes contain potassium chloride. They are taking, for laxatives, they are taking Kymchuran, as we found in about 1/3 of our patients. Very popular agent, A lot of them are on all kinds of friendly dietary therapies by their neighbors, trying all sort of concoctions. So if you're trying these agents which have, management of hyperkalemia, because that's a limiting factor in therapy, we all agree that. So I think managing hyperkalemia remains paramount. Yeah.
Okay, thank you so much. I think I want a one-liner from all of you, ARNI, today.
I think fantastic drug has changed our way of practice. It's easy to use. We already have experience with ACE inhibitors, ARBs. And I think if the blood pressure is not a concern, we must use it. And regarding the expanded indications, I think we are finding a role in resistant hypertension. I have been using in some of my patients who are not being controlled on the routine antihypertensive agents. And ARNI has a very good antihypertensive effect. So resistant hypertension is one area. HFpEF is another area where we don't have many drugs, especially if you have ladies, females, 55, 57% LV ejection fraction, hypertension. The Paragon actually showed a benefit in them, although it was a negative trial overall. So I think if we know the contraindications, if we know how to monitor the patient, probably we can use this drug. And I have, at my personal level, been able to avoid the device therapy in many of these patients. Dr. Neeru is sitting here, and we had one patient who was admitted with her on ventilatory support, similar to the kind which Dr. Gulati was mentioning, LV of 20%, tuberculosis, candidiasis, ECG changes, troponin positive, just not coming out, 1 month in the hospital, dialysis dependent. And as a compassionate use, we started ARNI. Today, the patient has an LV of 55%. We did an angio, that is normal. So such phenomenal thing we have not seen with any other drug. It's not that it's a sponsored symposium, I'm speaking so positively about the drug, but I believe that, and with SGLT2 inhibitors, I was very fond of using the SGLT2 inhibitors, I still am, but in last few days, what I have seen 2-3 issues with SGLT2 inhibitors. Number one, admitted patients, when you discharge them, many of them come back to you with UTI. They have been on Foley's and things like that. One of my patients who had a neurological issue, previous stroke, mechanical valve, this patient developed severe hypernatremia because she was not able to control her fluid intake. And many patients would not tell you, but patients with bladder issues, prostatic issues, they don't tolerate the SGLT2 inhibitors well. Nothing against them. But again, we need to know which patient will tolerate which drug. And I would say the usage and my confidence level in this drug has increased. The only point is maintaining the blood pressure, knowing when not to use, and monitoring the potassium levels. Dialysis is not a contraindication, as Dr. Gulati mentioned. And I think even with ACE inhibitors and ARBs also, if you are able to monitor the potassium well, I think it's not a problem. Many of my OPD patients who are following up with me regularly, if their potassium is around 5.3, 5.4, and they can do it once a month or so, I don't stop this drug.
Sir.
Thank you so much. We would like to wind up early
I
because we are
just want
lacking
to
with
make
the time, sir.
just one comment I want to make here is that as we came to know about the after the use of SGLT2 that they are more than drug for diabetes, I think ARNI also holds some kind of a future in for use in many conditions, and that is unfolding. That is other than heart failure. I think many other conditions might be in store, and we might be benefited. Thank you.
True. Thank you, sir.
Thank you so much. Thank you, Dr. Dang, and thank you, Dr. Grover, Dr. Kuba, and for doing excellent job. This is a little vast topic, which probably require more time to discuss about it. But a very take-home message from the young generation, what Dr. Kuba was saying it, don't totally rely on pro-PNB. Take a judgment on your clinical and echocardiography for heart failure assessment. And with the advent of ARNI, actually things have changed a lot, as has been told. Similarly, on the other side, empagliflozin and reticuloid has made an impact for the kidney failure, as Dr. Galati was suggesting. So, thank you so much.
In one of the conferences, I heard that if you want to manage the heart failure within a short span of time, that's within a 1 month, 4 weeks. So they have put this SGLT2 step 1 plus metoprolol, second ARNI, and third MRA. This was a regime within the shortest duration of time you can manage the heart failure.
Yeah, I think this is a very important concept that was put forward by Professor McMurray and Milton Packer. And they especially, in patients who have been recently admitted or post-MI, when the risk of arrhythmias and the risk of mortality is very high in the first few weeks, patients are hemodynamically compromised, may not tolerate ARNI. SGLT2 inhibitors and beta blockers may be the first line of therapy to begin with, because the highest reduction in arrhythmic mortality is still with beta blockers. I'm sorry we didn't discuss beta blockers today, but I think they are very, very important drugs. We know that. And second is SGLT2 inhibitors do not alter the hemodynamics much, so they don't cause much of hypotension. And third is if the patient has hyperkalemia, SGLT2 inhibitors can be easily used in them. So I think at the end of the day, all these 4 drugs act in unison as companions rather than competitors. The idea is by the end of 4 weeks to 6 weeks, we must try to put all these drugs on board, especially in the moderate tolerable dosages, instead of trying to achieve the maximum possible dose of one drug and then instituting the other drug, which was the concept which I was taught in my MBBS MD days. But now the concept is maybe start 2 drugs simultaneously, initiate the 3rd drug after a week or so, monitor the potassium, initiate the 4th drug. So if somebody has a BP of 150/90, heart failure, HFpEF, I think I would start ARNI, potassium is okay. Somebody has a BP of 90/95, I've done his angioplasty, MI, his LV function is 20-25%, his BP is 90/60, maybe I'll just start a low dose of beta blocker and SGLT2 inhibitor in him.
Thank you, Dr. Shamir Kuba. Thank you, everyone. I think we'll take question later because we are running behind already.
Thank you. Because of paucity of time, we'll stop it. Otherwise, heart failure can go on for a few hours more. Thank you.
Thank you, sir. I would request Dr. Anupam Prakash, sir, to please come to felicitate the panelists and chairpersons. So moving ahead with the next session, I would now request the chairpersons for the session to come to the stage and be seated. Dr. Meenakshi Jain, Director, Max Healthcare. Dr. Swati Jani, Consultant Internal Medicine at RML Hospital. Dr. Vandana Garg, Senior Consultant Internal Medicine at Max Vaishali. And Dr. Kush Ohri, Associate Consultant of Medicine at Max Vaishali. I would also request the speaker, Dr. Richa Chaturvedi, Senior Consultant and Endocrinologist at Apollo Hospital, to the dais.
Good afternoon, everyone. We invite Dr. Richa Chaturvedi, who is a senior consultant in Indraprastha Apollo Hospital, to start the session.
Thank you, Chairpersons. So, there is extensive evidence that impairments in mitochondrial content, function, and structure, and subsequent increases in oxidative stress play a major role in the pathogenesis of type 2 diabetes mellitus. Imiglimine, a tetrahydrotriazine derivative, is the first in class of glimins. Imiglimine, by the name of Twymig, was launched in Japan last year, 2021, and in India, it was launched last year. And the imiglimine is synthesized in single-step reaction from metformin. We add acetaldehyde to a solution of metformin, sodium hydroxide, and water, and we get imiglimine. So there is a partial similarity with the structure of metformin, but there are important differences also. Imiglimine has a cyclic structure, has important differences in function also, as we will discuss. So imiglimine and the glimins, they target mitochondrial bioenergetics. So let us look at mitochondria, structure of mitochondria first. There is an outer membrane, then there is intermembranous space, and then inner membrane. Inner membrane has these finger-like projections, which are called cristae, and basically they increase the surface area of electron transport chain and oxidative phosphorylation. So it gives us, more power to the powerhouse of the cell, which mitochondria are. So the three major functions of mitochondria are reactive oxygen production, apoptosis, and ATP generation. So here, let me stop and tell you about ATP generation a little bit in short. So what happens? Glucose enters into the cytosol, and in cytosol it is converted to pyruvate. Pyruvate enters into the mitochondria, and in mitochondria it goes into Krebs cycle or TCA, and it forms NADH. NADH is an electron donor. Then as for fatty acids, they come to the cytosol, then they go into the mitochondria through the action of rate-limiting enzyme CPT1, and in mitochondria, beta oxidation of fatty acids occurs, and the acetyl coenzyme is formed, which enters TCA cycle, and it forms FADH2. FADH2 also is an electron donor, and it enters the electron transport chain. So, as we can see on the inner membrane of mitochondria, all these complexes of electron transport chain are situated, complex 1, 2, 3, 4, and 5. So, NADH, an electron donor, enters the mitochondria through complex 1, FADH2 enters through complex 2, and they move forward. And while these are transported across the electron transport chain, the free energy is released, and because of this free energy, protons are pumped into the intramembranous space, and they form a sort of electrochemical gradient, and which serves as energy driver for ATP synthase, and by which complex 5 finally synthesizes ATP. So that's how ATP generation occurs. Now, how are these reactions coupled, ATP generation and insulin secretion? With this ATP generator, there is closure of ATP-sensitive potassium channel. With that, on the plasma membrane, and with that, there is opening of voltage-gated calcium channel. So calcium comes inside, there is calcium influx, and with that, with the incoming of calcium, insulin granules, they fuse into the plasma membrane, and finally, insulin secretion occurs. So mitochondria help in ATP generation, and then subsequent glucose-stimulated insulin secretion. So that's how it occurs. Another important thing we were talking about, important function of mitochondria, is reduction of apoptosis. So whenever cells are faced with increased oxidative stress, what happens? There are mitochondrial permeability transition pores, they open, and the apoptosis initiating factors, cytochrome C, caspases, they are released, and cell death occurs. So what does imiglamin do? It decreases reactive oxygen species, and the oxidative stress is reduced, and there is lesser opening of mitochondrial permeability pores, and with that apoptosis also is reduced, and this function is particularly important in beta cell to reduce beta cell death. While I was talking about this electron transport chain, the forward movement, I also would like to mention, mostly the electron transport movement is forward, but sometimes some electrons are leaked. They, instead of going forward, they go backward. So this is called reverse electron transport or electron leak, and they go through complex 1, and they donate the electron to complex 1, and from complex 1 the electron will go to O2 and make it superoxide, and the superoxide, the electron will be donated to H2O, forming H2O2, and which becomes a harbinger of highly reactive free hydroxyl radical, OH minus radical, so which is a reactive oxygen species, and excess of these reactive oxygen species will be causing cell damage. So that's apoptosis, which is decreased by imiglamin. So imiglamin, the USP of imiglamin, the important part of action is that it addresses all these 3 defects in the causation of type 2 diabetes. It acts at beta cells, and it increases glucose-stimulated insulin secretion, as we saw by increasing ATP generation, also by other maneuvers like increasing NAMPT, increasing NAD. NAD also is it is an electron donor and helps in oxidative phosphorylation. Then it has other actions on muscle as well as in liver. In liver, it decreases oxidative stress and decreases gluconeogenesis. In muscles, it increases insulin signaling and stimulates glucose uptake. So that way, it is different from other major classes of anti-diabetic agents. It improves mitochondrial bioenergetics, targets multiple organ systems affected by type 2 diabetes mellitus. It works at beta cell, muscles, as well as liver. So we were talking about structural similarity between metformin and imiglamin. So there are important differences also. As for metformin, we are still unraveling the ways metformin works. There are various ways we still don't know about. But looking at this mitochondrial pathway, metformin basically is inhibitor of complex 1. Complex 1 is the major site where reactive oxygen species is produced, and metformin binds with it non-competitively. There is stronger binding. With imiglamin, there is lighter binding, competitive binding. So reduction in reactive oxygen species is more with imiglamin, less with metformin, and metformin does not help in forward movement of electrons. It does not help the oxidative phosphorylation. There is insulin release with imiglamin, but as of now, there are differing views, but not much with metformin. And insulin resistance decreased by both, and hepatic glucose production, which is the main way metformin acts, it is increased by both. So if you look at the pathogenesis of type 2 diabetes mellitus, young onset and later onset diabetes, they both have mitochondrial dysfunction. Looking at genetic factors, mitochondria, they have their own DNA, which is apart from nuclear DNA. And this mitochondrial DNA is sort of ill-equipped for repair mechanism. So the damages in mitochondrial DNA, they keep accumulating and later on cause mitochondrial mutations. Then there are nuclear DNA mutations also. So type 2 diabetes is a polygenic disorder. As of now, around 18 genes have been implicated, which are important in the causation of type 2 diabetes. And at least 2 of them, these WFS gene, Wolfram syndrome, and HNF1 beta, these are associated with mitochondrial dysfunction. In environmental factors, obesity, that causes the overwhelming of oxidative phosphorylation. There is, so much of fatty acid going inside that it is not able to go inside mitochondria because there's a gatekeeper, there's a rate limiting step, CPT1. So it's not going inside. It will, it will convert into products like LCAC, long chain acetyl coenzyme A, which further converts to DAG, diacylglycerols and ceramides, which are well-known mediators of insulin resistance. So with obesity, intrauterine malnutrition, insulin resistance increases. So with mitochondrial dysfunction, there is beta cell dysfunction, impaired insulin secretion. There is beta cell failure because of increased apoptosis by reactive oxygen species. There is abnormal fusion, fission, and autophagy, that is decreased remodeling of mitochondria and beta cells, and there is increased insulin resistance. And all these factors together, they cause type 2 diabetes mellitus. So that's how imiglamin functions. Looking at some special aspects of imiglamin, well, it has been tried in renal impairment. Imiglamin is mainly excreted unchanged in urine, so it is very important to look at renal clearance and its use in renal patients, but it has been tried. What I can say, that it should not be used in recommended dosage of 1,000 twice a day in renal dysfunction patients. If we are using in renal dysfunction, then we should decrease the dose, 500 twice a day, less than 45 ml per minute GFR, and in less than 15, it should not be more than 500 OD. In hepatic dysfunction, mild to moderate hepatic dysfunction has been used. There is not much data in severe hepatic dysfunction. Contraindicated in pregnancy, in elderly, there is not much data in people more than 75 years, but otherwise, there is really no contraindication. So looking at important clinical evidence, there are 3 pivotal trials with imiglamin, times 1, 2, and 3. Times 1 was monotherapy trial where it was compared with placebo, all phase 3 trials. The dosage used in all these 3 trials was 1,000 milligram twice a day. So in times 1 monotherapy trial, imiglamin proved to be superior to the placebo. In times 2, very important trial, phase 3 randomized controlled trial, around 700 patients, and trial ran for 52 weeks. The primary endpoint was safety and secondary was efficacy. Now, all these patients, they were using single agent at the baseline, or placebo, or DPP-4, sulfonylurea, glinides, biguanides, thiazolidinediones, AGIs, SGLT2 or GLP-1 receptor agonists. And imiglamin was administered orally as combination therapy with approved hypoglycemic agents. And with all these agents, the HbA1c reduction at the end of 1 year, it ranged from 0.12 to 0.92%. So the maximum reduction was seen with DPP-4 inhibitors, and that was the reason many companies sort of hurried to file an application of DPP-4 inhibitor plus imiglamin, but they were turned down because of insufficient data by DCGI. And the least reduction came with GLP-1 receptor agonist, which was minus 0.12% reduction in HbA1c. Times 3 was on top of insulin. We are always on the lookout of oral agents which can be used with insulin so as to optimize glycemia along with decreased risk of hypoglycemia. We want to use as less dosage of insulin as possible so that we can decrease the risk of hypoglycemia. So times 3 was, it was a 52-week trial, initial 16 weeks. Placebo was used in one arm, and then in the second arm, imiglamin was used. After 16 weeks, all patients received imiglamin, and they looked at HbA1c reduction at 16 week, which was the primary endpoint, and imiglamin proved superior to placebo in decreasing HbA1c when it was used on top of metformin. Then they did CGMS, and they did effect of imiglamin on time in range. So this was imiglamin versus placebo, 32 patients, and 32 patients were taken here, and imiglamin was used for 4 weeks, and then they did 24-hour CGMS, and we can say the whole glucose 24-hour glucose profile is shifted towards appropriate glucose range. So time in range was increased by imiglamin. So this was an important phase 2 trial where they used imiglamin for around 16 weeks, and they did 3-hour OGTT at different endpoints and measured the indices of beta cell function and insulin sensitivity both. So for beta cell function, they looked at area under curve, which we can see on the right side. The dotted line is at the baseline, and the solid red line is after 18 weeks. So area under curve of glucose is shifted downwards in appropriate ranges. So it was helped by imiglamin, and imiglamin significantly improved fasting plasma glucose and HbA1c. And these patients were metformin non-responders, and metformin was washed out for 4 weeks, and then imiglamin was used. So in metformin non-responders, imiglamin was able to help and able to bring down fasting plasma glucose as well as HbA1c. Then the sensitivity indices like Strum-Wall index, it was significantly affected. There was significant benefit with the use of imiglivin. In Matsudo index, there was numerical reduction, but not statistically significant. So insulin resistance also comes down with imiglivin. Then they also looked at safety in CKD. As I said, it is excreted through kidney unchanged, so it is important to look at safety in CKD. They looked at population pharmacokinetics and did simulations and extrapolation studies, which suggested that in patients with the GFR of less than 45, you should use a dosage of 500 twice a day and not more than that. And this was initial data done by the manufacturer, study done by manufacturer Poxel, and they sort of looked at use of imiglivin in type 2 diabetes mellitus, CKD, and it is important to see in patients with CKD because they are more prone to have lactic acidosis, but there was no increased incidence of adverse drug reaction, including lactic acidosis. Then in rat models also, they saw important changes in LV left ventricular function, and which in some which appeared to be independent of glycemic effect. Then this is the Indian study which clinched the approval of imiglivin by Indian regulatory agencies. So they took 114 patients, put 114 patients on imiglivin, 72 on placebo. All these patients were early diabetic patients, and they were not well controlled on LSM. And imiglivin was given for 16 weeks in 1000 BD, and HbA1c and FPG and PPG were measured, and there was significant reduction in all these three parameters, and there was negligible difference in the side effects. So to summarize, imiglivin unique points are: there is complementary HbA1c reduction when it is used as monotherapy. When it is used on top of metformin or sitagliptin or SGLT2 inhibitors or insulin, it increases both insulin secretion as well as sensitivity, and improves both first phase as well as second phase insulin secretion, improves 24-hour glucose control, and importantly, it has placebo-like safety profile, so very well tolerated in our patients. Thank you very much for your kind attendance.
That was excellent session, Dr. Richa.
Thank you, Dr. Richa, for excellent session. I just want to ask you one thing. Where do you place this drug in the diabetes algorithm? Maybe now or maybe 5 years down the line? And what is its recommendation for use in India right now?
See, I will say drug will require more data in our, as of now it has huge preclinical data in rat models, but little less data in clinical data in humans, but still, very encouraging results. As we saw in Indian study, those patients were drug naive, and it was used on top of lifestyle modification. There were significant reductions. So because side effect profile is so, it's so good, so people are saying, why not use it as first-line agent, after lifestyle modification? There are more chances of tolerance. I would say, as of now, with the available data as we have right now, I use it in difficult patients, when it is, difficult to control patients who are reluctant for injectables. There it plays a role, and apart from that, I have used in patients who are on high dosages of insulin with brittle diabetes, more chances of hypoglycemia. So in such cases, if we can use, safer agents, it will be helpful. So apart from adding DPP, metformin, and SGLT2 along with insulin, this is also one choice we have now that we can add without exaggerating the risk of hypoglycemia, and at the same time we can decrease the dosage of insulin. We are still learning. I think we can use at any stage depending on your discretion, but in some patients who are absolutely reluctant to start insulin, this is one more choice that we have right now.
Yeah. So right now, I think patients who are metformin intolerant in early diabetes,
yes,
the drug has been
there
used very
will
well.
be good to place it, yes.
And secondly, I feel that it has a mitochondrial, it reduces the generation of reactive oxidation species. So people who are more prone for maybe atherosclerotic events or other complications like diabetic nephropathy and hepatic complication, people who have a bad family history, maybe in those patients we can use it as an initial drug or as an add-on drug, but we require more experience
yes,
and more personal data,
yeah,
because drug has not been approved by FDA as yet.
Encouraging preclinical data, but we will await human trials for really give a definitive comment on that.
But I think it would emerge as a promising drug in near future because it's mitochondrial dysfunction improving pathway.
Thank you, Dr. Richa, for the wonderful session. We would like to take any questions from the audience. Otherwise, we can close the session. Thank you.
Thank you. Thank you.
Thank you. I would request Dr. Kuldeep Dhar to kindly felicitate the speaker and the chairpersons. For the final session, which is a panel discussion, I would like to invite the chairpersons, Dr. Antul Dhiman, Senior Consultant, Dr. Charu Goyal, Senior Intensivist, Dr. Sushil Tyagi, Senior Consultant. The panelists are also invited to be kindly seated. I invite Dr. Neeti Agarwal, Senior Consultant, Endocrinologist, Max Patparganj, Dr. Neeru Agarwal, Senior Consultant and Director, Nephrology, Max Vaishali, Dr. Nilesh Kapoor, Senior Consultant, Internal Medicine at Yatharth Hospital, and the session will be moderated by Dr. P.N. Chaudhary, who is Senior Consultant and Academic Head at Max Hospital. I invite you, sir, at the dais.
So hello everyone, and I think this session name would be changed to intermittent fasting, right? Okay, because this session is we and lunch is waiting there outside. So Dr. Ajay said get no lunch before this session. Dr. Paras is laughing, right? So I think Chairperson Dr. Sushil, can we start? Right. So diabetes in special situations. Actually, it's a vast topic. So most of the things already have been covered. So we'll take on that which has not been covered, right? So Dr. Nilesh, Dr. Neeti, Dr. Neeru, and I think they are experts in their fields. So I'll start with Dr. Neeti. Like pregnancy is a very important issue, right? Because treatment of diabetes in pregnancy, over diabetes or GDM. So suppose MNT, we all know that MNT is the most important treatment for diabetes. And if suppose MNT fails, now how you convince your patients? Because we know that insulin is the only answer. And sometimes patients feel, okay, I don't want to take insulin. So what is your take on that, Dr. Neeti?
Thank you, and thank you. So for the question, so in pregnancy, in gestational diabetes or in type 2 diabetes with pregnancy, in both the situations, other than medical nutrition therapy, we have to give insulin. That is actually the only approved therapy. So, in fact, on a lot of occasions, we don't wait for MNT to work really. We have to simultaneously give MNT education and insulin. So, yes, there are hurdles, there are initiation problems. A lot of patients don't want to take their insulin, but a lot of counseling, and that there the role of educators does come in. So we definitely have to educate the patient with regard to the role of insulin. Beyond that, the oral hypoglycemic agents which we talk about, metformin has been used. It has been used for a long time now. However, after 2018, there were 2 studies in patients, basically in children. The follow-up studies from PCOS data in patients who were given PCOS, metformin in PCOS and then followed up. So it was found that the children who were born to GDM mothers or type 2 diabetic mothers, they had higher waist-hip ratios, they tended to be more obese, and they were the next generation of diabetics coming in. So the newer guidelines, they do not recommend the use of metformin, basically. So
right, I think so metformin is an important drug which has been used, patient already on because they become pregnant, and we wish that they should continue with metformin. So there's a lot of controversial data which is emerging, and you rightly said the latest data has been come up, right, that patients who are on metformin, the offsprings are a little higher in weight, and they tend to get obese or they tend to get type 2 diabetes in later in future. So we are still skeptical, but most of the patients actually patient metformin, the patient have been continuing metformin, and those patients who are metformin, the insulin requirement are also becoming less,
Yes,
right?
that is also
So it's a very edgy sort of issue that the patient when should start metformin, shouldn't start metformin, not. Dr. Nilesh, what is the state on that? Because it's a very important issue regarding metformin in pregnancy, GDMs.
So metformin can be given in the initial stages, but eventually I think insulin is the mainstay of the treatment, and we should stick to that because the results are also better and overall long-term impact is also better.
Right. So Dr. Niti, was one other question that suppose insulins, right? So what are the safer options available with us with insulins? With Risperdal, because initially, of late, the Degludec has also been approved for use in pregnancy now. So the options have been a little magnified now, yeah.
Yes, there are many options actually, for that matter. All recombinant human insulins, they are actually approved for use in pregnancy. So, yeah. So they are actually approved for use in pregnancy, but other than that, the analogs have been commonly used, and they are approved. The Lispro and Aspart are officially FDA approved for use during pregnancy. Beyond that, Levemir has been, approved for use for quite some time now, and recently Degludec was also approved.
Right.
Similarly, use of glargine has been used actually.
Right, so
Though
people
there
have
does
been
not-
using glargine in pregnancy, but actually it has not been FDA approved.
It does
It has
not,
not
it's
get
not
approved.
officially approved, but it has been used without any, there are studies actually available wherein there is data to say that there's no real adverse effects, long-term adverse
Sometimes
effects.
we cannot do a trial on pregnant women, and I think glargine has nothing, because if you use glargine, we have seen a lot of prescriptions of glargine
Yes,
on
we do come across.
GDMs,
Though
with
personally, I don't use it,
Yes.
but yes, we do come
Right.
across.
So Levemir, and I think NPH is the old.
NPH is
yes,
like
yes.
a recombinant, the version of the
Levemir,
recombinant.
now Degludec, and all human analogs can be used, and human insulins definitely are safer options. So we have a lot of choices in insulin when the GDMs are concerned. So I don't wish other aspect that comes in the special care of diabetes is surgery, right? Because most of the patients who are going to surgery are either not controlled, or surgeons say, okay, I have to do a surgery, right? And so there are issues of managing those patients that, okay, surgeons say that it's an emergency, we have to do it, and A1C is 9%, fasting is 200, and postprandial is 300. So how you deal with these patients?
Sir, I think we should start with the proper evaluation of the patient first, and I think any perioperative period, the first thing is that the risk stratification of the patient is important. Secondly is the important thing is that if there is a kind of a basal insulin going on, then the dose reduction as per requirement. The risk of hypoglycemia is more than hyperglycemia, but as the case that you pointed out where the hyperglycemia was on the more side, so I think the strategy is to first control it, say maybe 2 to 3 days back, and once things are under control, then maybe do for an elective surgery. If it is a kind of a emergency surgery, then obviously we can control it with rapid acting insulin and a dextrose solution. So I think it is easier to control hyperglycemia vis-a-vis risk of hypoglycemia, and we should be wary of using metformin because of risk of lactic acidosis, SGLT2 inhibitors for risk of euglycemic ketoacidosis, and even your high dose insulin, if it is longer acting insulin, if it is being given, then it should be dose reduction should be started at least 3 days before the surgery. So I think these are some basic things that we need to look at. And obviously on the day of the surgery, if already the patient is on a pre-mix insulin, then that has to be given in at least half the dose. So something of that sort we need to take care of.
So you need to look into that patient would not go to hypoglycemia rather, because hypoglycemia can be controlled, but sometimes the patient goes on hypoglycemia during surgery or perioperative, post-operative, then it would be a risk to that particular patient, in fact. So regarding that choice of insulins, okay, during perioperative period, sometimes patient has to go to emergency and sugar is very high. So what is the role of insulin infusion? That sometimes we can give insulin infusion, or sometimes the neutralizing concept is there that you neutralize insulin. So what is the approach on getting the insulin infusion? How the route of administration of this?
So obviously, if hyperglycemia is there and the patient is at the hospital, then obviously continuous infusion are a better option.
Right.
And we should focus on regular monitoring and just kind of managing the patient using continuous infusion. I think that is the best option.
And what about neutralizing? Because sometimes in nursing homes, smaller setups, they don't have infusions, pumps, right? So they neutralize the thing, but they are high chance of getting into hypoglycemia rather than hypoglycemia. So I think it's a risky issue when we neutralize the infusion.
Sir, I think the nursing care here is to be most important thing, because a lot of times our action point or action is taken by the nurses. and we as doctors are merely in the supervisory position. And if things are not kind of managed properly by the nurses, if they are not trained and if they are not handling situation properly, the risk of hypoglycemia is more. So I think training of nurses is important in this case, and also continuous monitoring.
So I think education is the key, and we should educate, because being physicians or diabetologists, actually we should educate our nursing staff with how to monitor, how frequently to monitor, and that's why it's important care, especially in the perioperative phase. It's very important.
Yes, sir. Most of the times, the compliance of the order that a physician has given is poor, and that is what the reason behind these episodes.
Right. So Dr. Neeru is there. He's heading the Department of Nephrology at Max Vaishali, and we are dealing with a lot of patients with CKD. In fact, we are suffering CKD, that how we should go ahead with the management of diabetes. Dr. Neeru, suppose the patient is oral hypoglycemic agents and patient has developed CKD. So what are the drugs, which are the safer options to be given in CKD as far as the oral hypoglycemic agents are concerned?
Diabetes is a menace, and CKD is seen in about 30 to 50% of cases. As the number of diabetic patients are increasing, the number of CKD is also proportionately increasing. So if actually it depends upon the GFR of the patient. If GFR is more than 50%, then routinely, like you use metformin as a first-line therapy, that is to be used in any patient. But if the GFR is less, like it is between 30 to 45%, you can reduce the dose of metformin, especially it is in all those patients who are obese also. But if GFR is less than 30, then in that case, you should not introduce metformin, or if the patient is taking it, you should try to withdraw it and switch to other short-acting sulfonylurea, or you can switch to insulin also. So this is about metformin. Then there are many other drugs which can still be used in diabetics who have CKD. So amongst them, sulfonylureas, glibenclamide, like Emeril, glycazide, glipizide, they are the short-acting ones. And they are mainly metabolized by the liver. So they are safe in CKD patients. But here, glipizide and glycazide, they are better because there's a complete metabolism from the liver, plus their metabolites are inactive. Glibenclamide or Emeril, it has active metabolites. Therefore, if you are using it in any of your patients, you should monitor the sugar values and try to reduce the doses as per the GFR and blood sugar monitoring. But it is actually a personalized approach. Then there is...
So I think sulfonylureas are actually not contraindicated in patients with CKD, but though is a half-life, as this glimepiride is a very half-life of more than 24 hours. Sometimes patient would develop severe hypoglycemia in the patient of CKD, right? So we should be very, yeah. So there are other options that we have glenites options, right? Because glenites has a shorter half-life, and they can be safely used in patients of CKD.
Even in ESRD patients, they can be used safely. Then comes the DPP4 inhibitors, like your sitagliptin, linagliptin, sexagliptin, vildagliptin, all these, they can also be used in renal failure patients. But here, linagliptin can be given at any age, but all other three, they are to be modified. If the GFR is less than 45, the dose should be reduced to half. If it is less than 30 ml per minute, then the dose should be reduced to 25% of the original dose. So this is how you can give OHAs, but you need to monitor the GFR and keep on reducing their doses. And then come SGLT2 inhibitors and GLP-1 analogs. SGLT2 inhibitors are new drugs. They are not usually used as a single drug. They are used in combination with other drugs. GLP-1 agonists are new drugs. If your patient receiving the OHAs not very well controlled, and you see that CKD is there, is still progressing, proteinuria is not under control, then these are the two drugs which can be added.
Right. So the linagliptin, the dose cannot be changed because it can be given at 5 mg because the excretory pathway is hepatobiliary rather than this renal, right? And it's very important to calculate eGFR in every patient. Sometimes we used to forget calculating eGFR. And it's very important because if the eGFR is less, the metabolism is definitely delayed and the patient would develop hypoglycemia in such cases. So every patient of diabetes, you have to calculate the eGFR.
Even now, most of these good labs are giving
they are
calculated
giving
EGFR.
EGFR rates.
So the modification of drug, as ma'am said, is easily possible.
Right.
Plus the role of SGLT2 inhibitors is, they are good drugs and they are being used in a very low EGFR also now, ma'am. So a lot of our patients, like ma'am says, also using, we cross a lot of patients. So we are using in very low EGFR. I mean, now even it is approved in up to even less than 20 EGFR. So they have a lot of role in CKD patients.
Not in case of glycemic control, but other
Yes.
preventing diabetic kidney disease, progression of proteinuria, and end-stage kidney disease. That's a wonderful drug, and we have been using. Definitely, the issues of GTIs are always there with the patients, so we have to give the cautions.
That caution always goes
And
while using SGLT2
especially in elderly
inhibitors.
elderly CKD, we have to be little cautious because of risk of hypertension and other infections. So other very important aspects that are usually asked in different conferences regarding the fasting time, that how you manage this diabetes in fasting, especially during Ramadan. So what is your approach in this?
Yes, sir. So Ramadan is a special case because here there is a prolonged fasting. So basically there is a daily fasting and then it is continuous for too many days. So the patient takes a morning meal, that is suhoor, and then he takes an evening meal, that is iftar. So there are a lot of fluctuations which can happen. There are a set of patients who are prone to hypoglycemia. So there are studies which say that a patient, if they have an episode of hypoglycemia prior to Ramadan, then there is an increased risk of hypoglycemia during Ramadan, and vice versa. If the patient is having a kind of uncontrolled diabetes, the chances are that towards the time of sunset, that is towards iftar, and after that, the episodes of hyperglycemia are more. So both are equally kind of problematic, but important is that we should avoid hypoglycemia. So if a patient is already on sulfonylureas, I think that is the first step that we need to take care of. That if we can take him off sulfonylurea. Second step is to look at the premix insulin. If we can avoid that somehow, if affordability is not a constraint, then better put him on a basal bolus regimen. And the third thing is that we need to reduce the dose of basal insulin prior to Ramadan, because that is important to take care of the fasting episodes, and eventually to load kind of your dose towards your suhoor also, so that there is no hyperglycemia.
So the patient who are on sulfonylureas, what is your approach? Patient already on sulfonylureas.
So, sir, eventually we would like him to be off sulfonylurea, so we will try to shift him to SGLT2 inhibitors or DDP4, or maybe any other molecule if possible.
So I think DP4 inhibitors are a very good choice in patients with during Ramadan, and they have least incidence of hypoglycemia in those patients. Another issue comes with a patient with elderly. Sometimes it's very difficult to manage diabetes in elderly patients, especially who are living alone. So what is the advice on those patients that how you manage the diabetes with concern with insulins or with concern with oral anti-diabetic agents? So which are the safer options of
increase in longevity, the number of elderly diabetics is going up. So this is another area where definitely needs to be taken care of. So we, as sitting on the other side of the table, we need to understand the situation of the elderlies first. So whether they have good caretakers, a lot of elderlies are living alone, and what are their comorbidities which also have to be taken care of, what medication they're on, what is their cognitive status, whether they are able to understand therapy. So these things have to be actually looked into, and not just a straight, there's no straight thing. So you actually have to individualize therapy for patients. We need to individualize the goals actually first. So the goals for geriatric population should not be very tight.
Right.
We need to consider the risk of hypoglycemia. So whether the patient is actually able to take insulin or not. If somebody is having an essential tremor, the patients are not able to take insulin. So it's like a very individualized therapy. We may have to alter the doses of insulins if they are on insulins, maybe decrease the sulfonylureas to decrease the risk of hypoglycemias. And even SGLT2 inhibitors, there are sometimes these patients, elderlies, they are able to manage, but some people are not able to manage with the risk of infections. So,
right, so just a minute, just two questions. Regarding this very important point that you have to don't be very strict in goals when you are dealing with elderly patients, right? We said, okay, 7%, but in that case, if can keep your goal to 7.5, even 8% in those patients to just avoid hypoglycemia. So, Dr. Nilesh, that we have discussed that how you carry insulin when you're traveling, right? So, but if you travel longer hours, like if you're a patient going to US, and so what is your advice for insulin patient already on insulin? So, what is your advice on that particular patient?
Yes, sir. So, as Dr. Saurabh also said, when we are traveling along the longitude, so north-south or south-north, there is no issue. But if you are traveling across the longitudes, especially to the west or east, and there is a kind of traveling across the time zones, and there is more than 3 time zones, then obviously there are implications. So, when we travel to west, then the days tend to become longer, and when we travel to east, the days tend to shorten down. This is the basic principle which everyone needs to understand. So if the days are getting longer, then the dose has to accommodate for that, in the sense that your meals will become more. So there might be a need of a rapid acting insulin that will be required as per the meal. And vice versa, when we are traveling to the east, and then the days get shortened, so we need to reduce the dose of the basal dose to take care of the shortened duration. So I think this is the major implication that we need to take care of.
Basically, I think the NPH can be preferred over long-acting.
So again, it is very imperative that the patient should not be on the premix insulin, because that will create complications. It's better to shift him to a basal bolus regimen at least 2 weeks prior to travel.
So last question to Dr. Neeru, as Bell is getting, no? So what is the choice of insulins in patients with CKD? Whether you are using longer-acting insulins or you are using the rapid-acting insulins, because the lifespan of insulin would also increase when you give a short-acting insulin also.
Very true. The half-life of insulin is prolonged in all the CKD patients. And the problem here is, if you give them full doses, they will definitely land up in hypoglycemia. Nocturnal hypoglycemia is very common in CKD patients. So we usually prefer basal insulin because it is slowly keeps a continuous slow control of the blood sugar. And if the sugar values are high, then you can add very short-acting insulin for the morning hours and lunchtime, and in the night you would prefer a smaller dose of shorter insulin if required, or basal insulin would cover in the night.
And of late, Decortec has also been said it is also safer in CKD patients. In fact, few of my patients are actually well controlled with 2 doses of regular insulins, right?
Yes.
So the regular insulin becomes premix actually in the particular CKD patients, and no issues of hypoglycemia in particular patients. So that definitely we have to individualize according to the patient's comorbidities and thing. And I think this is a very vast topic. So I think with this we end this topic, and if any audience or chairpersons have any comment, then we can.
Thank you panelists for the nice discussion about the special situation every clinician faces in day-to-day practice. Definitely this discussion has changed our insight, our knowledge about management of diabetes in these special situations. I want to ask a comment on the use of management of diabetes, particularly patients who are on glucocorticoids. This is a very common situation we encounter in daily
This question was
practice.
there in my list, but actually because of paucity of time, because it's very important. During COVID time, we have seen that patient have on steroids and patient has uncontrolled diabetes, the blood sugars ranging from 400 to 500, even 600. So it's very difficult to manage those patients, particularly when the patient was admitted in the hospital. So I think this Dr. Niti would say that how you manage these patients.
So again, this is to keep it really brief, I'll try. But again, it is very vast because it actually depends upon the type of steroid that you're using. The timing at which time you're giving. Mostly the steroids most often being used is prednisolone and is usually given around, after breakfast, most often. So again, the setting in which the steroid is being given, whether it is being given in the inpatient setting or it is being given in the outpatient setting, plus also how long it is intended to be used, because a lot of rheumatological illnesses, they will give a long duration of, many years of steroid intake. So there are a lot of things which actually have to be assessed before we actually decide the treatment. If it's a short duration we are looking at, then giving a single dose or of maybe a premix insulin around breakfast time would probably suffice. But sometimes the interesting thing here is that with steroids mostly, the fasting would come out to be normal, while through the day the sugars are likely to remain high. So that role of NPH is here. Beyond that, some patients with a longer acting steroids may require a single basal insulin dose. So, which could be anything, so digludec or glargine or anything. Sometimes, in certain settings, especially in the IPD settings, we may have to actually give basal bolus regimens. Now again, it will depend upon whether the patient is on enteral feeding, parenteral feeding, patient is orally accepting. So therapy that way has to be really individualized again. Patients who are on parenteral therapy would probably, as during the discussion it came up, so may have to actually just give a neutralizing regimen. Patients on enteral would have, extra short-acting insulins before every feed. And those who are on oral may just require some oral hypoglycemics, or even in this setting with steroids, I would like to make one mention that with the role of SGLT2 inhibitors, we have to be very cautious, because in the risk of infections would actually go up. So that way, though they are great drugs, but we have to be cautious, especially the use of steroids. We can just
So if the patient is got admitted, definitely we have to off this SGLT inhibitors in that case. And there's no role of oral hypoglycemic agents in management of steroid-induced hypoglycemia. The treatment of choice would be insulins. And it all depends upon which steroids you are using, what is the half-life that particular steroids have on timings. And it's also very important when you use to taper off the steroids, the dose of insulin should also be tapered off, because we don't remember this thing, and patient would go into hypoglycemia when the level of steroid goes off. So I think this is how we could manage these patients.
Thank you. Thank you very much for the panelists and audiences. Thank you, everyone. Now we close the session.
Yeah,
thank you.
Thank you. I request Dr. Bimal to kindly come and felicitate the speakers and panelists. And finally, before the conclusion, I would like to invite the entire team for valedictory. Over to Dr. Nishesh.
Good afternoon, everyone. I won't take much of your time. First of all, I would like to invite all the faculty members from the organizing committee to come over the dais. So, Dr. Ajay sir. Nishant. Grover sir. Pankaj sir. मैं बोल देता हूँ, है ना. Thank you everyone. Thank you to all our seniors, colleagues and friends who spared their time on this Sunday. Thank you very much. बोलते हुए ये फोटो